all the delegates who have joined me. And it's indeed a very prestigious association with my teacher, Dr. Martin Keszler, my colleagues who have done so much work on high frequency, Dr. Anton from Amsterdam, and Dr. Manuel Sanchez from Spain, and my colleagues, Dr. Dushan Batra, Dr. Sajad Rahman, Dr. Basuraj, Dr. Sridhar. We all have been doing high frequency for quite some time. And I think it is a very auspicious thing to get Dr. Martin to inaugurate this as chairman, because almost 4 decades of HFO. And before I go into a session, I must focus on certain bottlenecks and areas of high frequency evolution, which he'll be talking. But I think the most important thing which Martin stood in the late 80s was the HFO and HFI trials. Those were the days we were panicking to start, how to start HFO, whether we should first recruit the end expiratory pressure or just do high frequency and everything. But Martin put the whole game plan into our head in the maybe the late 80s and 90s. So it's only after Martin set up that the foundation of HFO is end expiratory pressure or CPAP. It rang a bell into my head. And from then on, I never looked backward. That was the turning point in HFO in all the first decade, means around late 80s to late 90s. In 2000, we became smart. And in 2010, we became more smart. We started dealing with volume guarantee for HFO, which Manuel will be talking about. But on the spin side, I feel that the HFO in VG is not taken off like it should be, because it's almost 10 years old. So this conference brings out all the World Cup batsmen of HFO in one composite symposium.
Good evening, everyone. Very warm welcome to all of you. And I would like to thank my colleagues. Dr. Rajiv has worked really hard to reach this stage with this symposium. I mean, he has connected with the international renowned experts. We are very lucky to have Dr. Martin Keszler, Dr. Anton, and Dr. Manuel Luna, all of whom have done a lot of work, pioneering work in this field. And we will have, I'm sure, a great academic session. I mean, in terms of experience, obviously, I'm junior to Dr. Rajiv, and I trained in PGH Chandigarh, where we had the high frequency ventilation. We had the baby log, which is Martin's baby. So obviously, we had baby log, and then when I moved to UK, we had the sensor medics, which was a very powerful high frequency ventilator. And it's quite an enigmatic field because it's totally different from conventional ventilation, and we need to really understand what we are doing when it comes to high frequency, because you can help the babies, but you can harm them quite easily as well, especially when you're using something as powerful as sensor medics. And for the past few years, the Drager VN500 as well as the SLE 6000 and other ventilators have come up with sophisticated modes with high frequency. The DCO2 monitoring is an advancement. The way we adjust frequencies, previously we didn't go above 10 to 12 hertz, but now we are going 50 to 20 hertz, as we will hear from Dr. Luna for the tiniest babies as well. So it's interesting. The field is advancing, and obviously we are looking forward to a great session today. There will be a slight modification of the titles of Dr. Keszler's talk, because the first one will cover the historical and the basic aspects, and the second lecture will cover the practical applications of high frequency as well. Now I will invite Dr. Manoj to invite Dr. Martin Keszler to start his first talk as well, because we are starting the session live now. Dr. Manoj, do you want to take over and introduce Dr. Martin? I know he has a very long CV, but he specifically requested to keep it brief. So thank you.
Thank you, Sridhar. Ladies and gentlemen, I do not think Professor Martin Keszler needs any introduction to those of us who actually practice neonatology. Consider this. In the early years of neonatology, when prevention of ventilation-induced lung injury and practice of gentle ventilation were still very new concepts, we had Professor Keszler telling us that targeting volumes while ventilating neonates improves most of the outcomes. Such is the greatness of this man. I consider myself fortunate for all the interactions that I had with him so far. And I'm honored today to introduce him once again in this session. I'll be very brief. I'll skip half the things that I want to say. Dr. Keszler is a professor emeritus of pediatrics and one of the most esteemed researchers at Brown University. He obtained his medical degree from McGill University and his pediatric and neonatal training at Children's Hospital Medical Center, Akron, Ohio. In 2010, Dr. Keszler joined Brown University from Georgetown University in Washington, D.C., where he was professor of pediatrics, chair of IRB, and medical director of NIC and director of ECMO. He thereafter served on the advisory board of the maternal fetal medicine units of networks of NICHD and was vice chair of the data safety and monitoring board of NICHD neonatal research networks prior to becoming an NRN investigator upon joining Brown. Martin has published numerous original papers, review articles, book chapters, and editorials, and presented over 300 lectures at national and international conferences. Moderator or conducted over 50 workshops or roundtable discussions, and is a visiting professor in over 20 medical institutions in USA and abroad. So without wasting any more time, ladies and gentlemen, let's hear from this legend of neonatology on the evolution and classification of high-frequency ventilation. Over to you, Professor Keszler.
You are most kind, and you give me far too much credit, both of you, but thank you nonetheless. Dr. Rajiv has also been far too kind. Can you see my slide?
Yes, sir.
Okay,
Yes.
just making sure. So it's a great pleasure to have an opportunity to share with all of you some insights over how high-frequency ventilation has evolved over many years. I was fortunate enough to be there, not quite this far in 1915, but at the beginning of clinical application. The whole concepts did start with a gentleman who noticed that his dog was panting very shallowly and yet did not appear to have any problem exchanging air. And he demonstrated that with rapid blowing down a tube, you can have a spike of gas penetrating through the resident gas. And that was sort of the earliest concept that taught us that you can ventilate at tidal volumes that are near or perhaps even below anatomical dead space. And so the basic concept of high-frequency oscillatory ventilation is that unlike conventional ventilation, where when we apply pressure at the airway opening, that pressure results in flow down the tracheobronchial tree, and pressure eventually equilibrates all the way down to the periphery, and then exhalation can occur. With high-frequency ventilation, these swings in pressure occur very rapidly, and there's no time for pressure to equilibrate. And therefore, there is really more of a mixing of gas and complex mechanisms of gas exchange. But the key concept is that as we move peripherally down the tracheobronchial tree, there is progressive attenuation of the pressure and volume swings. And that is one of the two key aspects of lung protective nature of high-frequency ventilation. The other, I will tell you as a spoiler to Dr. Van Kaam's presentation, is of course optimal lung volume recruitment. So my task was to briefly discuss classification of high-frequency devices. And so I will tell you that there are basically three modalities. Not all of them are widely available everywhere. HFOV is the one most widely available throughout the world. And of course, that generates a symmetrical waveform at a 1-to-1 ratio, or somewhat asymmetric if you choose different ratios. The waveforms are generated by a variety of mechanisms. The operating frequencies range from 5 to up to as high as 20 hertz. Some of the older devices don't have the ability to superimpose recruiting psi, others do. Jet ventilation is primarily available in the US and Canada. There are a few devices in Europe and Australia. This is an exciting and novel way of ventilating. I will spend just a handful of slides to describe it in more detail. It has a lower optimal operating frequency because it depends on passive exhalation. Essentially gas shoots down the airway and returns passively. And then there is something called high frequency flow interruption or percussive ventilation that again generated by a variety of mechanisms. The difference between flow interruption and jet ventilation is that with flow interruption, there is a the gas enters the airway without going through that jet nozzle. Some of the flow interrupters do have a negative inflection, a somewhat of an active exhalation, but not nearly the same magnitude as the inspiratory flow. So there's been much discussion over the years about what constitutes a true oscillator, and there's been some misinformation and misconceptions out there because the baby does not care how the waveform is generated. The baby's lungs care about what is the waveform, what does the waveform look like? And so what makes a true oscillator is a device that can generate a true sinusoidal waveform with equal positive and negative pressure deflections. And it doesn't matter how that is generated. So at 1-to-1 ratio, it's both positive and negative are of equal magnitude. If you use a 1-to-2 RE ratio, the pressure deflection will be less, but the volume deflection is equal. So equal volume of gas, equal flow goes in and out, and that makes a true oscillator. Some of the older devices clearly were not quite up to that. So how are the oscillations generated actually is quite variable, and some companies kind of try to keep it a secret. Some are mechanical piston oscillators. The Hummingbird was the prototype of that, and they still use a mechanical piston, which pretty much limits them to a 1-to-1 inspiratory-expiratory ratio, and that turns out may not be optimal. Then, of course, there is the loudspeaker, so-called piston oscillator, and that's the prototypical oscillator, the Sensormedics 3100, and also I believe the Dragonfly uses the same mechanism, although that was hard to find. There are other oscillators, other devices that no one argues are not oscillators that generate the deflections by a reverse jet mechanism, the SLE, for example. The Stefan device uses sliding valve system that directs gas flow to or away from the patient. And then there are several devices that use a powerful venturi or membrane to generate the negative deflection. Again, what matters is it a symmetrical waveform of equal magnitude going in and out. So there are lots of different devices out there. And it's important that we understand the device that we're using so that we know its limitations and we know its strength and we know how to optimally deploy it. There are some devices historically that were out there that were true flow interrupters. The Infant Star was one of them. And several fairly large studies were done using that device, and they did not have very good results for reasons we'll discuss in a moment. The Bronchotron is a US device and is not available elsewhere. The old Babylog was somewhat of a hybrid between an interrupter and an oscillator. It did generate mostly adequate expiratory deflection, but it was not a powerful enough oscillator. In some circumstances, it had limitations. The new Draeger is a much more powerful device. So there's been a lot of studies that suggest that the not quote unquote not true oscillators are not equally powerful. It's true that, for example, the Draeger VN500 does not quite have the same horsepower as the Sensormedics. But I will tell you that few of us use high-frequency ventilation needing a tidal volume of 15 mLs. In fact, of course, typically we are going to use high frequency at high frequencies. Whoops. And for my purposes, tidal volume of 5 ml is your biggest baby you're typically going to ventilate, right? 5 ml per kilo. No, you typically use 1.5 to 2 mLs per kilo. So up to 2 kilo, you do fine. And if you use a slightly lower frequency, you can generate what you need. There is this well-known relationship between tidal volume and frequency that is reflected here. So we had spent a lot of time over the years arguing about which ventilator is better, but we, I think, can finally overcome that, and we can look back at a wise person who wrote an editorial in 1965 that points out what we have all come to learn over the years, which is that arguing about virtues of respirators not invented over those readily available can be ended now that it is abundantly clear that the success of such apparatus depends on the skills with which it is used. In other words, it's not the hammer, it's the carpenter. It's how well we are using the device at our disposal, because not everyone has access to the best devices. And yes, some devices are better than others. But if you know what you are doing, you can do well even with not the greatest machine. It's what you have. You have to use it carefully, use it well. All right, so the other task was to kind of take us through the history of high-frequency ventilation. And Dr. Rajiv gives me far too much credit, but it started really clinically in Scandinavia. Dr. Sjöstrand in 1960, something called high-frequency positive pressure ventilation. This was employed in adult patients. It worked. It had benefits. Then people moved on to oscillatory ventilation with some bench experiments. Dr. Lunkenheimer in 1970s, using a piston oscillator, demonstrated in principle you can very effectively ventilate. And then the jet ventilation began to be used in adult patients. Dr. Sanders started using it during airway manipulation. And 2 Czech doctors, Mira Klein and my dad, Hugo Keszler, worked in Pittsburgh on some clinical applications of high-frequency jet ventilation. So I came into this with some pedigree, I should point out. Then there were folks in Toronto, in Canada, who developed clinically some application of oscillatory ventilation in the 1980s. Bob DeLemos down in the US was instrumental, and there were many others that followed. So really clinical application of jet and oscillatory ventilation began in the late 1970s, early 1980s, with jet ventilation being perhaps slightly ahead in terms of clinical application. Tom Harris, Steve Boros, and I was probably the second or third person to put a baby on a jet ventilator. We did not publish our work immediately, though. And Wally Carlo, Alan Spitzer were also very active in the use of high-frequency jet ventilation. And as I said, we spent a lot of time arguing about whether oscillators or jets are better. Turns out it doesn't matter which you use if you know how to use it well. So back in the early 1980s, this was a jet ventilator that I used. It was a fluidic device. It was quite interesting. We applied the jet through a homemade jet injector. Could not do that today, should not do that today, but that's how we all began a very long time ago. So my early career in high-frequency ventilation involved the jet ventilator. The Bonnell jet came into being in the mid-1980s after I finished my fellowship. And it was an interesting device, microprocessor control, the first neonatal microprocessor control device that has this pinch valve close to the patient and shoots little bursts of gas down the center of the airway, monitors the pressure distally, and adjusts the amount of gas that's being injected to maintain a stable pressure that the clinician chooses. It's a newer device, but it's functionally much the same. This is essentially how it works. So the gas exchange mechanism is somewhat different from oscillatory ventilation. It shoots bullets of gas down the center of the airway. displacing gas that's resident there. There's some simultaneous exhalation that occurs. It can bring up secretions. If you start jet ventilation on a baby with meconium aspiration, you sometimes flood it with meconium. But what's important with the jet ventilator and what's make it a little bit tricky to use is that this jet stream needs to be carefully aimed down the center of the airway. Should not be too close to the carina. You don't want a head turned to the side because the endotracheal tube comes in at an angle and this jet whole thing is broken up. On the other hand, you can take advantage of this jet streaming by what I call a virtual right mainstem bronchus intubation. And if you have unilateral interstitial pulmonary emphysema, as you have in this patient with tremendous overexpansion and tension, you can virtually, and in smaller babies, then, you know, even a 2 millimeter endotracheal tube may be too small to actually intubate at mainstem bronchus, but you can virtually intubate by aiming that jet stream. And within 12 hours, there's not complete resolution, but the tension has gone away and there's considerable improvement, and this baby continued to improve. So jet ventilators have some unique characteristics that make them particularly useful in air leak, but they're not available everywhere. So then in the mid-1980s, we all started using high-frequency ventilation, but there were really no good clinical trials. So a group of investigators got together and organized this hi-fi study group. I was invited, but chose not to participate because they chose to use a ventilator, a hummingbird ventilator, which I did not think was actually the best way to go. We were therefore not involved in that study. And unfortunately, that study proved to be quite disappointing. As you can see, many of the outcomes were quite poor, with actually increased air leak, increased need for pressors, increased intracranial hemorrhage, periventricular leukomalacia, and failure of assigned therapy and crossover. It was a very disappointing study. There was a lot of speculation what went wrong. Big part of the problem was that we did not really fully understand how to use high-frequency ventilation. There were many investigators that actually didn't have any experience with this device. Clearly, they did not target the output lung strategy. But perhaps the problem also was the use of the hummingbird piston oscillator with a 1-to-1 IE ratio and without lung volume recruitment, because that can cause air trapping. All the adverse consequences that you see here could in fact be explained on the basis of air trapping. They did not publish any radiographic data. Most of these could also be explained on the basis of inadvertent hyperventilation, certainly the PVL and IVH. And so we really don't know exactly why this trial was so disappointing, but it set the field back many years. In the meantime, though, people persevered, knowing that in their hands, those were not the results that they saw. And perhaps it was because the Sensormedics oscillator that also came on the market in the mid-1980s and has not appreciably changed since, has come into use, typically being used with a 1-to-2 IE ratio, but it has some limitations. It is a dumb ventilator. It doesn't know if you have a thumb over here, a cork at the end of the circuit, or a patient. So we have better devices now, but it is still the most powerful device. And of course, the way oscillators work is there's an electromagnetic piston that moves back and forth, generating these oscillations. The power applied to the magnet determines the amplitude and therefore CO2 elimination. And there's bias flow of fresh gas, and the balance between inflow and downstream resistance sets your mean airway pressure. And it's therefore quite a simple device. You have an oxygenation knob and a ventilation knob, but there is an interaction between the amplitude and mean airway pressure that affect both oscillation and ventilation. It's not quite as separate as people make it sound. So we have very good data over many years of preclinical work that taught us how to use oscillatory ventilation. There was a very nice study published in the year 2000 by Brad Yoder that demonstrated long-term ventilation. This oscillatory ventilation was much more benign in terms of causing lung injury than conventional ventilation. You can see a well-preserved lacy pattern of alveolar formation in these baboons that were biopsied at 7 months of age after they were recovered following a long period of ventilation, whereas the conventionally ventilated animals had the typical new BPD pattern that we see today now in neonates. So there was a fair amount of activity as over the next 20 years or so. This is the HI-FI trial that was quite disappointing. The mean birth weight was 1,100 grams, so bigger babies than we worry about today. It was a large trial, but very disappointing. Wally Carlo published a small study using a jet ventilator with no immediate benefit, but it was a small study. Gratifyingly, there was no increase in intraventricular hemorrhage. I published a trial in 1991 using the jet ventilator. It was a modest-sized trial aiming specifically babies with severe PIE. Important to point out that this is the pre-surfactant era, and a time where conventional ventilation was quite quite brutal, quite poorly done. We did not have synchronization, and we did not understand the concept of volutrauma. So it was relatively easy, perhaps, to demonstrate benefit. So this clearly improved survival, and it did not have adverse consequences in terms of brain injury. Rees-Clark published a modest-sized trial in babies of similar size as the HI-FI trial and demonstrated that actually you can use oscillatory ventilation effectively and safely, no increase in intraventricular hemorrhage. Then there was another trial using the sensomedics in a rescue mode, babies with severe RDS, some with air leak, and mean birth weight was about 1,700 grams. There was a slightly higher incidence of IVH, and the PCO2 was significantly lower. So this is a recurring theme. We're going to talk about complications. This is one of them. We saw it in the HI-FI trial. They did not publish the PCO2 data. We saw it here. Then there was a study in the late 90s that had very good outcomes in both groups. Then surfactant came around and things got somewhat better, but we still had issues. And Dale Gersman published this work in 1995, moderate-sized trial. The mean birth weight was 1,500 grams. Who even ventilates babies of 1,500 grams today? Whoops, we're going the wrong direction here. So, yes, it seemed to work. There was less BPD and no adverse consequences, but this is not the population we treat today. Then there were two jet ventilation studies published around the same time. One with catastrophic outcomes, much higher risk of intraventricular hemorrhage and periventricular leukomalacia or death, but there was severe respiratory alkalosis. So that's a recurrent theme. Jet ventilators and oscillators are powerful devices that can really overventilate a baby. Virtually at the same time, we were running a multi-center trial in virtually the same population, mean birth weight very similar, gestational age very similar. And we demonstrated a reduction in BPD, need for home oxygen. There was overall no increase in intraventricular hemorrhage or PVL. But it was interesting that it was really a matter of strategy. They used a strategy that resulted in inadvertent overventilation, because with air leak, the low pressure strategy was appropriate. They applied that strategy to babies with a different disease, and that was the problem. There was a subset in our patients that was also, despite strict instruction to use the optimal lung volume strategy, that was not followed, that had similarly bad outcomes, but it was a smaller subgroup. And then there was a series of studies done in the surfactant era, but we're still talking about the end of the 20th century and the very beginning of this century. and they were generally good results, except for this, which used a flow interrupter that had no improvement in outcome, and an increased air leak. This study is another study using a 1-to-1 ratio with a French oscillator that showed lower PCO2 and increased intraventricular hemorrhage. You get, there's a recurring theme here. And then there were the two large trials published at the same time in the New England Journal of Medicine. Both were quite large studies, it's very similar population. And one showed a benefit in terms of BPD and one did not. And why might that be is still a matter of some debate. But you can see that in the UK study, there was no difference in survival free of BPD. In the US study, there was a benefit, and overall survival free of BPD was higher. It was slightly lower incidence of IVH, or high incidence of IVH. And so they were very similar in design, similar population. I showed you they were essentially identical in terms of the actual gestational age. There were some key differences, though, that I'll discuss in a little bit more detail in the second talk that deals with complications. Interestingly, long-term follow-up of the UK study did show benefit in terms of long-term pulmonary function. Essentially, the babies that were ventilated with the oscillator had less evidence of small airway disease. I'm not going to go into the details for lack of time. And then there was a slew of studies still in the more than basically 20 years ago or so, and a few more recent ones, one from India. I'm not going to go through all of them. Mostly they're quite small. This was a small study that did not that used sensormedics, but some infant star, and did not optimally. They said they used the optimal lung volume strategy, but if you look at the actual data, they really didn't, and there was no benefit. This was another flow interrupter study that had a strong trend toward more air leak. We don't use the infant star anymore. So I'm going to just show a summary slide of what we have in terms of the most recent meta-analysis published in 2015. And you can see there's significant heterogeneity in the findings, with some studies showing a benefit or a strong trend toward benefit, some studies failing to. And part of the problem with meta-analysis is that throws together studies using different devices, different strategies, in different eras, right? So 1990s, before surfactant, is a different population than the most recent one. This last study from China that seemed to show an implausibly large reduction in death or BPD was only published in a respiratory care journal, and I'm a little bit skeptical of the quality, and that's another problem. You're equally weighing New England Journal of Medicine publications with large cohorts to a small study published in an obscure journal. So there are some issues, but overall, I think notwithstanding all of these challenges, we can reasonably conclude that oscillatory ventilation, when used appropriately, when in experienced hands in the right population, using the right strategy, will improve outcome. But it has become more difficult to show benefit of high frequency as conventional ventilation improved, as synchronized mechanical ventilation became routine, as we began to understand that optimal lung volume strategy should also be used with conventional ventilation. And more recently, then actually that volume guarantee with conventional ventilation dates back to the 1990s. And that volume targeted ventilation has clear benefits over what the comparisons were back in at the beginning of high frequency ventilation. So that is the rapid journey through the evolution of high frequency ventilation. And you might ask, is there anything new? And of course there is. It's not that new, actually. As Dr. Rajiv pointed out, HFOV VG has been around for almost 10 years now. but it is not being used as much as I believe, and he believes, and many of us who, I'm sure Manuel does as well, is not used as much as it should be. And we will spend a fair bit of time talking about that. And with that, I will leave you. This is what happens when your funding runs out. If you want to read more about things, the flyer had a previous edition of the assisted ventilation book. There is a 7th edition out a couple of years ago. So thank you very much. I will stick around till the very end, so there will be opportunity to ask questions. And I will stop screen share. Thank you for your attention. Hello?
Hi, Dr. Martin. Thank you. Dr. Manoj, are you there?
Thank you, sir. It was an excellent journey. You have taken us from the past to the future, or rather giving some tips on what is going to be the future. Now, do we take up questions now, or is it at the end?
In the end, I think.
In the end.
I don't
So
need to
probably just to sum up Professor Keszler's amazing talk, we tend to compare different things and then try to see which is better, conventional or high frequency ventilation, and then we get confused. High frequency ventilation, when we did not know much about it, and then the conventional ventilation, when we used to target ventilation, and when you used to compare these two, then probably that might be the reason why the previous results are not in tandem with the new trend that is emerging. Back to the organizers.
Thank you, Manoj. And I think you're doing reasonably good work in your center. So
Yeah.
I think Tausik to take over the sequence.
No, Dr. Rajiv, I'll introduce you. It will be
Okay.
your talk next. So, good evening, everyone. And thank you, Dr. Martin, for an excellent overview of the historical aspects. I mean, it's a journey down memory lane for most of us, and for the newer doctors, especially the lessons we learn from the initial studies if you don't apply the fundamental principles. So that's an important lesson as well from this discussion. So next we will be moving on to a very important topic, which is the disease-specific applications of high-frequency ventilation. And we have Dr. Rajiv. All of you are familiar, and he has already been introduced briefly, but he's a consultant neonatologist who trained in India, as well as he had the opportunity to do a fellowship in Westmead Hospital, Sydney, and he also worked in US. He said, as in the beginning, in 1988, he was with Dr. Martin Keszler in US as well. And he has done pioneering work in the private sector in India. Most of the tertiary level neonatal care in India in the late 90s, early 2000s was in the public sector hospitals. And Dr. Rajiv established one of the first good NICUs in the southern India, in Kerala, in Kochi to be specific. He also had the opportunity to introduce use of sildenafil and PPHN in that region. And he has published many papers, and he has authored many books. The most important one was the neonatal ventilation textbook, which was recently published, and now the second edition is going to be coming soon. He has also authored multiple books on non-invasive ventilation, the one on practical use of CPAP as well. So without wasting more time on introducing him, I mean, it has been my pleasure to know him for a long time here, and we have been working together with the IAP Emirates, and I have to really say hats off to his energy levels and commitment. He has really single-handedly organized this symposium, bringing in the world caliber speakers as well for all of you. Over to you, Dr. Rajiv. Please start your presentation.
Thank you, Sridhar. And I move on. And I think Dr. Martin's lecture was very conducive to our lectures because we always have to know from history where we started. But I think I should focus entirely on my journey through so many specialists who trained me and made me get into mental software. So I could address any aspect of HFO with a good evidence-based practice. Now, to start the basics, you must understand that panting was the primary visual observation on which the whole evolution by Brand and Fries in the early 90s, this was able to give tidal volumes with effective ventilation very close to the anatomic dead space. And the frequency was around 2 Hertz, that means 120 breaths a minute. So this is the fundamental principle which you are not able to fathom in those days, how the dog was able to hyperventilate, in our words, and have effective gas exchange with less than that frequency of about 2 Hertz. Next slide. Now, this basis is very, very important to understand HFO. So whenever we deal with HFO, you only have to ask one fundamental question: are we dealing with CPAP? Yes. If you don't know your CPAP well, you cannot do HFO very well. So the first and foremost foundation of HFO is CPAP. So your mean airway pressure is entirely controlled on CPAP. And why I presented this visual thing is that there are various generations of alveoli when you ventilate a baby. Some will be optimally recruited, some may be overexpanded, and some. So you never have a homogeneous population of lung units. So in Dr. Keszler's brilliant, very old study of maybe 1990s, he has shown that over a period of time, when you ventilate a baby on HFO, there is a sequential de-recruitment of alveoli. So with this introduction, please understand lung units are not homogeneous. It is not a good diagram. But whenever you ventilate, please remember this, that your entire thing, even on conventional ventilation, the foundation is on CPAP or end expiratory pressure or MAP on HFO. Next slide. Now, again, when you have this concept in your mind, you not go wrong with the operations of HFO. It's a wobble CPAP. So unless you set your structure of the FRC properly, at that point in time, at any point, you can be recruiting the lung, or you can be in stable phase, or you can be weaning phase. At all points in time, you have to ask that fundamental question: am I operating at an optimal FRC or optimal lung volume, which Anton will be talking next lecture. And on top of that, you're blowing very nicely some tidal volume. So the contribution of your chest movement or tidal volume of Hertz is only minimal unless it comes to very powerful oscillators like sensormedics. There, the ventilator is so powerful that it can have a small effect on the mean airway pressure. So by and large, all ventilators, you can independently control the FRC or mean airway pressure and tidal volume separately, and with good results. So whenever you ventilate, this fundamental diagram should be in your mind. We are only oscillating on top of a FRC. Next slide. So if you have this fundamentals in your mind, that this is the foundation, you will never go wrong with your basis of doing HFO. Next slide. So to definition is of HFO is above 2 Hertz, above 120 breaths a minute. And generally in HFOV, we are trying with up to 15 Hertz. But now Anton has gone in Anton and Sanchez have gone in a different way. They're trying to ventilate with 20 Hertz. So my point is, if you're ventilating from 5 Hertz to 20 Hertz, you must remember another diagram, which I'm going to present shortly. Next slide. This is what we know. We all thought it for uniform lung inflation. It improves gas exchange, reduces air leak, and decreases inflammatory mediators and recover leukocytes. It improves gas exchange, reduces lung injury. This we all know. Next slide. So this also we know. But among all these evils, of barotrauma, volutrauma, apectrauma, and biotrauma. The most dangerous one would be volutrauma. Because as for Dreyfus' experiment in 1985, even 7 to 8 ventilator breaths can cause the start of lung injury. So obviously, there is a role for HFO in our clinical practice. Next slide. This is another one. It's a modification of Dreyfus study in 1985. Static strain means you're moving the piston up and down without much end expiratory pressure. So as the figures show you, you have tidal volume 100%, there is no end expiratory pressure. And you have tidal volume of 25%, but you have end expiratory pressure. They are totally different ballgames because the lung injury is affected proportional dynamic strain as per Dreyfus study. So this diagram all of us know. But finding the sweet spot, that is one area of over-inflation, we have safe window, and we have a zone of de-recruitment in the beginning. The sweet spot is not fixed. It keeps changing with time. So at all points in time, if you want to find a sweet spot, you may have to probably do some lung assessment by ultrasound, or what Anton is quite expert in, magnetic tomography, which is not in the clinical bedside. But in an ideal situation, we should try to work from a safe window. Next slide. Next slide. These are all single compartment models. Next slide. This is the de-recruited lung. This is a optimally ventilated lung. Next one. So overexpanded lung. So anything around 8.5 to 9 spaces, flattened diaphragm, we feel it is overexpanded. But X-rays are not so sensitive as we proved in clinical practice. Probably we should look at lung ultrasound, electrical magnetic tomography, which Anton is quite expert on. But by and large, the most important aspect of ventilation is to optimize your lung volume at every point of your ventilatory care. Next slide. So this is myself in 1997, fresh out of training from Martin Keszler. And every time I have a birthday, I buy one ventilator for myself. So that was my attachment to ventilatory care and its intricacies. And I was fortunate that a lot of very important people like Martin Ramanathan and Edward Bell taught me. So I could integrate what I learned from them appropriately at every point in time. Next slide. Next one. So these are the 6 principles of how the gas exchange of it, partly Dr. Martin's already told you. So we have to move the gas from the vocal cords down to the alveoli. It all depends on time constant. But in HFO, the principles are quite different because there's no conventional gas exchange except for this 5-6 mechanism. The first thing is called asymmetrical velocity profile. That means the fresh gas moves into the central part of the airway. The stale gas comes out of the peripheral part of the airway. The second is the regional mixing between 2 units called pendulum. Those with different time constants, they exchange gas. There is direct ventilation, and there is also radial mixing and turbulent flow. And these are the 5-6 mechanisms on which the HFO principles work. Next slide. So what it does is, the red one shows the fresh gas flow to the center of the airway. And by streaming, the stale gas and the carbon dioxide comes out the periphery of the airway. This is the optimal gas exchange occurring if you recruit the lung alveoli and your time constants are all right. Next slide. So this is a principle which you have to always keep in your software. You have to recruit the lung all the time and keep it open, because not only during the recruitment phase, but during the stable phase, also there's a tendency for some lung units to deflate because the time constants are different. Next slide. So if you remember this, HFO becomes very easy. The time bomb is the FRC or total lung volume. Even 1 centimeter change in this, if you do, you can either cause decreased venous return or you can cause overexpansion and air trapping. So you're only oscillating the air as a small waveform on top of the FRC or lung volume. Independently, you can control the CO2, the amplitude and the frequency applied. And independently, you can control oxygenation. I'm using the rough word CPAP to emphasize the importance of the index respiratory pressure or MAP or CPAP on HFO. So independently, you're controlling O2, but in volume guarantee, these things may slightly change. Next slide. So we are trying to prevent what is occurring in conventional ventilation and 8 ventilated breaths, the peak inspiratory pressure and the inspiratory time. So we're trying to limit pressure exposure with minimal tidal volume. So the code word for HFO is you should try to use minimal tidal volume and try to use the optimal CPAP to profess that you've done the ventilatory strategy well. Next slide. So the principle of HFO very simple. On CPAP or mean air pressure, you're oscillating a small amplitude of waveform. Next slide. This is an easy diagram to remember. Why I said PEEP is just to make you convinced that the whole thing controls the mean air pressure. So in HFO, it's mean air pressure. And this controls oxygenation directly. But this equation may change with volume guarantee. Next slide. So this is what we are taught almost 30 years back. I deliberately put it wrong for a certain amount of reason. If you see the arrows, they're all wrong. So if you are between 7 and 8 ribs, it was discussed by experts to increase the mean air pressure by 1. And if it was by 10 and 11 ribs, to reduce it by 1 centimeter. So the target ribs to be targeted is 8 to 9.5 ribs. This was the teaching almost 30 years back. Still holds good to some extent. Next slide. These are the machines which Dr. Martin discussed. Next one. So the primary difference between these two is that in conventional ventilation, it's basically the frequency into tidal volume to give the alveolar ventilation. Whereas in HFO, it is frequency into tidal volume squared, which is reflected as the carbon dioxide dCO2 or carbon dioxide elimination coefficient. Next slide. So in HFO, the dCO2 is called VT squared, tidal volume squared into frequency. Next slide. This is important. This depends on how you set the frequency of the hertz at the bedside based on the lung disease. It is based on the airway resistance, compliance, and the normal resonating frequency of the lungs. So normal lungs, it's in the range around 10 to 12, we set the hertz. And this curve shows that the compliance is good. So we are able to ventilate with this level of frequency. Whereas if you have increased airway resistance, automatically you have to push more air at a certain level of resistance. So your hertz has to be a little bit low. So the airflow with less hertz will be more, and the gas exchange will be more with lower hertz when the airway pressure is high, like in chronic lung disease. In situations of very low compliance like HMD, because the time constant of the lung, you can ventilate with much higher hertz, maybe 12 hertz, 15 hertz. And now Manuel is trying to ventilate with near 20 hertz, which we never did earlier. So our frequency in which we generally operated around 12 to 15 hertz for HMD because compliance was low. You can achieve it with a very low time constant. But in meconium aspiration syndrome, you have a combination of increased airway resistance and low compliance. So your time constant will be different. So you may have to ventilate with a hertz between 8 and 10, or maybe a little bit lower, depending on the state of the lung. Next slide. So now we come to amplitude, which is very simple to understand. The peak to peak swing through mean airway pressure. We try to target something around 40 to 55 when we do HFO. It's very, very difficult because in seconds, the whole thing had changed. So we have to keep a very close watch on the DCO2 when you ventilate a baby. And please watch the DCO2 trend. It can change in a few seconds time. Before you do the next blood gas, the DCO2 will change, and that will have a profound effect on the cerebral hemodynamics. Next slide. So whenever you reduce the stroke volume, as you increase the hertz, the stroke volume become less time for the piston to move. So if you want to increase the amplitude, you can do so to reduce the carbon dioxide. You can reduce the carbon dioxide by reducing the hertz. But bear in mind, whenever you decrease the hertz, don't do it casually, because the machine becomes very powerful with gas exchange. If it's not appropriate, the frequency, you can cause air leaks. So generally approach the hertz with great caution once you set it. And think carefully about the physiology before you change the hertz on the machine. Next slide. This is a pictogram. You can see the difference in the tidal volume displaced with 4 hertz and 8 hertz. And take it from me, you must keep a hand on the end of your T-piece and see the power of the machine if you come to 4 hertz. It is very, very powerful when you come to 4 hertz, the power of the machine. You just put a glove and hold the T-piece. So with this in mind, don't go to these frequencies below 7 hertz with great caution. Next slide. This diagram should always be in your mind. What are we trying to do with HFO is, we're trying to move backwards from 5 hertz, which I rarely do, up to 20 hertz, which Manuel Sanchez will tell you. So the process is that in this process, you're making this powerful machine into a CPAP device almost. If in inverted commas, I'm using CPAP because the chest wiggle will be a little bit less, and the power of the machine will be dampened entirely by the reach of 20 hertz. So you're basically transitioning a baby with a powerful from 10 hertz to 20 hertz, means that the mean airway pressure will be optimum for that thing, and the ventilator induced injury will be very less. So this diagram should be in your mind, and don't change the hertz unless you're sure about the physiology of the lung at that point in time. So any change inadvertently, you can cause air leak, especially with powerful machines like Sensormedics. They're very, very powerful. So if you go to a Sensormedic around 7 or 8, the machine is extremely powerful, it can cause air leaks. Next slide. And incidentally, lung bashing was a word used by Wang in 1985. I still believe, I like that word, lung bashing, when you try to chase carbon dioxide. This is a frequency setting which we generally use and which is universally applied. So I think 1000 grams, 15 hertz to start is good enough. Maybe 1 to 2 kilos, 12 hertz, and all term babies around 10 to 10 hertz. It's a using starting thing for frequency. And meconium aspiration, probably I would go slightly above 7 to 8. I will not go to 6 in the beginning. Next slide. This is a slide which all of us refer, but there is no much evidence based on this. It's all an accepted practice. And we can say that generally that word is good. 10 to 12 hertz for CDH. And if you have preterm HMD, 12 to 15 hertz. Term lung disease, 8 to 10. But this last part, established pi with high, this is not evidence-based. Because the machine which you use is going to be very extremely powerful. So here we have to do some permissive hypercapnia and hyperoxia. And I generally would not recommend this 5, 6, 7 that zone. think with great caution you should approach it. Next slide. So this is some trends between. So now the $1 million question is, what is the optimum lung volume at this point in time? So I think Sanchez and group will tell us that if you can target DCO2 and tidal volume, you can have an indirect measure of optimum lung volume, which is the foundation of HFO treatment. Next slide. This is my simplistic diagram, which I think Manuel will explain to you. So for simple people like us, please try to keep a tidal volume below 2 ml per kilo. So I've written a pictogram, anything goes above that, like 2.5, you may predispose that lung to air leaks. Next slide. This is the brilliant study done by Sanchez and group. It shows one without VG and one with VG. So you have DCO2 on the side. It changes with the hertz as the machine becomes less powerful with the frequency, as you can see here. And the beauty of the VG is the tidal volume remains almost same in all the frequencies. So your strategy for CO2 adjustment will be easier probably with tidal volume with HFO. This Manuel has to tell us about this. Next one. Next one. Next. So in CO2, the main control parameters are oscillator amplitude already mentioned, oscillator volume told DCO2 and CO2. Next slide. Usual sensormedics is 33%, but you must remember one thing very important. Don't change the IT ratio casually. If it goes beyond 1:1, there is increased risk of air leak. The moment you go less than 1:1, the transmission of airway pressure from the vocal cord down to alveoli will change. So next slide will tell us. So don't change inspiratory time inadvertently. Don't do that. Next slide. So the ideal thing for all practical purposes would be to use a 50%, that is 1:1, because the alveolar pressure and end expiratory pressure will be almost same. But if you try to shorten this without knowing the ventilator, then you may land up in a situation where the pressure transmission from the vocal cord down to the airway is not proper, especially in situations where if it is a hyaline membrane disease, that would be all right. But if it's not hyaline membrane disease, then the pressure transmission from the vocal cord down to the alveoli will not be proper. You're not ventilating the child properly. Next slide. Next slide. So this is how to open a lung. It's a recruitment manual. So you first open the lung and try to keep it open. Next slide. So this is from Suzuki in 1992. You have a lower inflection point, and from there the lung opens up. And after a certain point in time, you'll find that the oxygenation doesn't improve much. And in fact, you may slightly make the baby desaturate or hypotensive. From there, you go backwards into the downward limb to an extent that, again, the oxygenation, which has improved, becomes again going to desaturation. That is a lower inflection point. We are always trying to work at the lower inflection point in HFO. Next slide. This is from David Tingay. Whenever you ventilate a lung, think carefully about this, but never feel that the lung is a single homogeneous unit. It's made up of totally different lung units unless you're dealing with pure and simple atelectasis. Next slide. This is a lower inflection. This is lung deflated. Then as you go up on the pressure volume curve, next one, it is recruiting. The next one, it's again optimally recruited. Now it's overexpanded, the total lung capacity. And as you come down, you come to critical closing pressure, in which is almost same like your one you started the lower inflection point. So you are trying to ventilate the baby on the deflating limb of the pressure volume curve. I wish it was so simple. So when you utilize a recruitment maneuver, when initiating HFO to recruit lung. After disconnect or loss of FRC, after suctioning, inability to wean FiO2. Probably I would focus more on this. And when you want to consider increasing mean airway pressure. Next slide. Recruitment recruit lung allow me to maintain the baseline and thus not increase support. So this will keep you in the same point in pressure volume curve without using higher pressures. I started my career in 1997 with Infrastar, graduated to this sensor, this SLE, and used VN500. Next one. This and all is covered by Dr. Martin. Thank you, Martin. Next one. This from Martin's own reference 10 years back. He's already covered this. Next one. Generally, use a 1:1 ratio, but in a sensibility is fixed as 33% of the eye time, and that we cannot change it. Next one. So the indications to summarize: severe RDS, homogeneous lung disease, pulmonary interstitial emphysema. Martin has already told how efficiently it removes the air leaks, unilateral and bilateral. Bronchopleural fistula. I have seen the dramatic effect on this with HFO. Selective efficacy, the PPHN, meconial aspiration, pneumonia, diaphragmatic hernia, pulmonary hemorrhage, BPD. Next one. Established indications: PI, pneumothorax, respiratory failure responding to conventional ventilation, adjunct to INO, pulmonary hyperplasia. That's anecdotal. Next one. Next. This is what I like to do. So whenever the peak pressure goes beyond 22 in the preterm or nearing 25 in a term baby, I would do this. But by and large, if your oxygenation index crosses 13, our unit is very comfortable with HFO. But maybe now with conventional ventilation, with targeted volume, we may achieve. But by and large, in my unit, I would use HFO with oxygen more than 13. Next slide. Contraindication is extremely important. Before I start my lecture, I wanted to have a dictum. Please do echo before HFO. I think Martin will agree to that synonym. Do echo before HFO. It's extremely important because you can't do it with a slightly shocked baby or a cardiovascular dysfunction, because it's basically you're cutting off the venous return. So in the olden days, before I had access to echo, I used to always give 10 ml per kilo of saline. Check the posterior tibial pulsation, because those days we are all having not the luxury of so much of monitoring. But in HFO, the basic monitoring which at the bedside would be to feel the posterior tibial pulsation. If that is good, then you will know that your cardiovascular hemodynamic status is good. But if you have access to echo, do a preload, check the myocardial function, and then only start your HFO. So in this modern era, when everybody knows bedside echo, please do bedside echo before HFO. You can see that the ET tube placement, which Martin told, in certain cities, it may be just angulated towards the trachea. Then the issue of your mean air pressure transmission to lung is finished if it's angulated on the trachea. So do echo before HFO. In obstructive lung disease, be very cautious. You're already air trapped, but it can be used. Next slide. Failure HFO within not 2 to 6 hours, within 2 to 3 hours of adequate ventilatory strategy, failure to improve oxygenation by at least 30 millimeters. I think that is good enough. In 2 to 3 hours, you have a good strategy. You're not improving oxygenation by 30 millimeters. Please proceed to the next step. Next step. Next one. Next. Now, to summarize what myself, let's start with Dr. Martin first. Dr. Martin, myself, Anton, we're all driving this for the last almost 30 years. Okay. Now, Manuel Sanchez has come with his HFO with VG, but we will be worried to accept the principle of this because, next slide. It is very, very important what I'm telling this. HFO is a wonderful tool in the right hands, the right strategy, the right lung. So your hand means your experience with that machine. You can't be using InfluenStar and then comparing with sensibilities. Similarly, your strategy of recruitment of lung volume should be sound on your experience and should be the right lung. Suppose you use a strategy on a wrong lung like diaphragmatic or a wrong lung where the baby is shocked, it doesn't work that way. Next slide. Last slide. Next one. There's one more slide. No. There was one last slide. Anyway, I'll just tell it verbally. My study to be published within the next few days is a study of high frequency on PPHN and randomized to use one limb on nitric oxide and one limb sildenafil with an OI of 15. We found that the failure rate in sildenafil thing was around 19%, and INO was definitely better. But the neurodevelopmental outcome of these babies at 7 years was strikingly different with sildenafil compared to nitric oxide. I think that slide is not there, but it will be published in the next 3 days. Thank you very much.
Thank you, Dr. Rajiv. Very interesting slides and well illustrated as well. It was a fascinating journey, and the last question you posed hopefully will be answered today by Dr. Luna. And we will have questions for your session in the end as well, as we discussed. And now we will move on to the next session, which will be chaired by Dr. Sajjad. Dr. Sajjad is a consultant neonatologist, well known to most of us in the United Arab Emirates. He's a consultant neonatologist and director of the Neonatal Fellowship Program, as well as clinical director at the HMG hospitals in Riyadh and Saudi Arabia. So being brief with the introduction of Dr. Sajjad, welcome you and thank you for joining us today. Please proceed with introducing Dr. Anton, and thank you, Dr. Anton, for joining us as well.
Yeah, thank you very much. I think it's better for you to introduce because I don't have the part of the CV I should have. Hello?
Thank you, no problem at all.
Yes, please. Thank you very much. Appreciate that.
So I'll be brief with the introduction. Of course, most of you know Dr. Anton, who is one of the pioneer researchers on high-frequency ventilation, and he has written widely as well as written many chapters on high frequency as well. He's working in the neonatal intensive care unit. Actually know very well about his work on high-frequency ventilation. As we discussed and as Dr. Martin requested, we'll keep the introductions very brief, and obviously, hopefully, Dr. Anton, you'll be able to stay till the end, or we'll have questions at the end of this session.
No, I have to leave after the talk, so sorry.
Okay, so we will have questions for
fine.
you at the end of your talk. So please proceed with the lecture. Thank you so much.
I'm going to share my screen.
Yes, thank you. Thank you. Welcome, Dr. Anton.
Can you see it?
Yes.
Yes,
Okay,
yes, we can.
Thank you very much. Okay, thank you. So thanks for the invitation. Pleasure to join you on this wonderful webinar. And I'm going to focus in my talk a little bit more on the strategy of high-frequency ventilation. And these are my disclosures. So I think it's important to ask ourselves the question, is this webinar still relevant? Do we need to talk about high-frequency ventilation or ventilation whatsoever? Because as you all know, we are managing our babies more and more on nasal CPAP. And this is some data from the US where they looked at the modes of respiratory support for babies, preterm babies below 32 weeks over the years 2008 up to 2017. And you can see here in what's indicated in blue is the percentage of babies that actually was ventilated at some point in time during their admission. And you can see there is a slight decrease over the years, but still 50 to 60% of the babies below 32 weeks end up on a ventilator at some point in time during their admission. And in the dark blue, you can see that, well, roughly of these babies, a third will actually be treated with high frequency ventilation. So I think it's important to talk about high frequency as one of the modalities that we can use in our newborn babies. It all has to do with bronchopulmonary dysplasia. Of course, you all know it's a multifactorial disease, but still, mechanical ventilation is considered an important risk factor in the development of bronchopulmonary dysplasia. This was nicely shown by a cohort study in the Italian network, where they tried to identify risk factors for development of bronchopulmonary dysplasia. And as you might expect, one of the risk factors they found in their cohort was, of course, mechanical ventilation. What was really important for me, and I think important for you too, is that they also looked at ventilation duration. And as you can see, they divided ventilation in 3 groups, up to 24 hours to 7 days, and more than 7 days. So basically, if you have a very brief ventilation time of less than a day, you don't see that much of an increase in the risk of BPD. But as soon as you cross the 1-day ventilation, you can see there's almost a 2.5 increase in the odds of developing BPD. And it's even a lot larger if you ventilate babies for more than 7 days. So the key is that part of the strategy that we are discussing is, yes, we could use high frequency ventilation with an optimal ventilation strategy, but we should also aim to extubate the baby as fast as possible back to nasal CPAP. So if we talk about strategy, and we talk about lung injury or ventilator-induced lung injury, we need to have a closer look at these risk factors, because they can actually help us in identifying what the optimal strategy should be in our babies. A lot of animal data. This is data from a preterm lamb model, lambs with RDS, where they clearly showed that if you have increasing tidal volumes during conventional ventilation, you will also get an increase in ventilator-induced lung injury, expressed on the left side in the yellow bars with protein leakage in the lavage fluid, and on the right side in a compliance of the lung. What has not been appreciated by neonatologists for quite some time is the important risk factor called atelectasis trauma. So the presence of atelectasis in the lung is considered an important risk factor for ventilator-induced lung injury. Again, illustrated by these studies in preterm lambs with RDS. If you ventilate these lambs with 0 PEEP, positive end expiratory pressure, thereby allowing a lot of atelectasis present in the lung, you can see that there is more lung injury compared to animals that were ventilated with a PEEP of 4 centimeters of water. The way this works is there are different mechanisms, but what's most important is that atelectasis can actually result in what we call regional alveolar overdistension or regional water trauma. And I try to illustrate this here on this slide. So on the left side, you can see the tidal volume that you set as a clinician, measured at the Y-piece, and let's say it's 6 mL per kilo, which we would still consider to be in the safe range. So if we have no atelectasis, the lung is fully open, you can clearly see that there is, especially in the whole lung, 6 mL is actually delivered to the open alveoli. But if 50% of the lung is atelectatic, we must realize that the 6 mL, as you set as a tidal volume, will only reach half of the lung. And at the regional level, these alveoli will actually be ventilated with 12 mL per kilo, resulting in regional volume trauma. Finally, we also know that oxygen is a toxic drug. We know from animal studies that if we ventilate animals with 100% of oxygen, we will get additional lung injury in these animals. So if we're not careful, we can end up in this circle where we have a baby who's failing nasal CPAP and needs to be intubated and started on mechanical ventilation. And by causing ventilator-induced lung injury, we get edema in the lung, inflammation, and surfactant inhibition, which will aggravate increase the level of respiratory failure, you need to increase your ventilated settings, and then you get stuck in this vicious circle. So what we want to do when we talk about lung protective ventilation strategies is that we want to minimize this pathway of mechanical ventilation reaching ventilator-induced lung injury. So if we know what is causing the lung injury, we can also define our strategy. If there is collapsed alveoli in the lung, we need to first recruit the lung and then keep the alveoli open during both the in and expiration phase. You want to prevent end-inspiratory overdistension by using the smallest possible pressure amplitude, resulting in a small tidal volume. And of course, you want to reduce oxygen concentration and thereby oxygen toxicity. And all of these aspects, all of these items together is what we would call optimal lung volume or open lung ventilation. Now, why is high frequency as a modality such an attractive modality if you want to have lung protective ventilation? I tried to illustrate this in this slide, where we have in the yellow the typical pressure trace over time of conventional ventilation, where you have a relatively low PEEP, a high peak inflation pressure, and you can see a large delta pressure also. In contrast, if you look at high frequency ventilation, we have sort of a continuous high mean area pressure, or how we like to call it, a continuous descending pressure. And on top of this, you have these high frequency, very small pressure amplitudes. And we've seen this in the other talks, that if we know what are the zones of lung injury, either overdistension, so the volutrauma zone, or atelectasis in the atelected trauma zone. And you can see that if you look at the pressure trace of the conventional ventilation, you are moving through these zones of lung injury, and hopefully with high frequency ventilation, by using a higher mean area pressure and a very small pressure amplitudes, you actually will be ventilating your baby within the safe zone. Some terminology that I will be using in my talk. So we have the mean area pressure or continuous descending pressure. On top of this, we have the delta pressures in a very high frequency, up to 600 to 900 per minute. Of course, you have the bias flow in the FIO2, and you have an inspiratory and expiratory phase. So the key question, if we are discussing strategies with high frequency ventilation, is that every time you use high frequency or start to use high frequency, or before you're using high frequency in your baby, you ask yourself the basic question: what is the underlying lung disease? And to me, there are actually two options. Either there is recruitable lung disease, for instance, surfactant deficiency, or surfactant inactivation, or a baby with NEC with abdominal distension and the diaphragm being pushed up really high into the chest. These are conditions that we would call recruitable lung disease. On the other hand, you can also have babies who do not have recruitable lung disease, but you would like to use the high frequency ventilator to avoid the risk of overdistension and air leaks. For instance, babies born after premature rupture of the membranes where there's a considerable risk of lung hypoplasia, or babies with congenital diaphragmatic hernia. This needs a different strategy than in recruitable lung disease. So first, let's have a look at high frequency in a recruitable lung disease, which is the mainstay in use of high frequency in the population that we treat in our neonatal intensive care units. So we know here that there are several aspects, and especially we need to know how to recruit the lung and make sure that we avoid the atelectasis. You could ask yourself the question, how important is recruitment? Because by design, by just hooking up your baby to the oscillator, you will actually get very low tidal volumes, 1 to 2 mLs per kilo. So it is really important to also reduce the atelectasis by lung recruitment. And this was addressed in an older study many years ago, where they randomized rabbits to be ventilated for 7 hours, and they were randomized to either conventional ventilation, indicated in red, Animals were randomized to high frequency, but without recruitment procedure, so allowing still a lot of atelectasis present in the lung. And in yellow, you will have the animals that were randomized to high frequency, but also with a recruitment procedure trying to optimize lung volume. And you can see here the pressure-volume relationship of the lung after 7 hours of ventilation. You can see that in terms of the pressure-volume relationship, this is almost completely destroyed in the animals that were treated with conventional ventilation, as indicated in red. And you can see in yellow, you can see the optimal pressure-volume relationship in the animals assigned to high frequency with lung recruitment. And look at the blue pressure-volume relationship. Animals that were treated with high frequency ventilation, so having the small tidal volumes but no recruitment, you can see there's already a sort of an intermediate deterioration of this pressure volume relationship. These are our adult animal models. We, together with David Tingay in Melbourne, repeated these studies in preterm lambs with RDS, again randomizing them to high frequency ventilation with an optimal lung volume strategy or allowing atelectasis to remain in the lung. You can see, as indicated in yellow, that optimizing lung volume again resulted in a better pressure volume relationship compared to no recruitment. So the key message here is that yes, the small tidal volumes will give you lung protection, but you will only get the full benefit of lung protection with high frequency ventilation if you also recruit the lung and reduce atelectasis. So the key question is, how can I recruit the lung? How can I measure atelectasis at the bedside in my patients? I know we discussed chest x-rays already in the previous talks. What should we aim for? What is the optimal lung volume on a chest x-ray? But I think we need to realize that the correlation between the chest x-ray and the true lung volume is not that great. It's shown here in this study where they assessed the lung volume with a tracer gas washout technique, so the gold standard on the y-axis, and on the x-axis they had a calculation of the optimal variation by looking at the conventional chest x-ray. And in the triangles I highlighted here are the babies that were treated with high frequency ventilation with lung recruitment. And you can see there's actually not a real correlation, a good correlation between the actual gold standard FRC and that measured with conventional chest radiography. It also is very practical to have the chest x-ray because you can't make an x-ray every 5 or 10 minutes while recruiting the lung to see what it actually is the lung volume at that point in time. So we need a more direct online tool to guide us through the process of lung recruitment. And actually there is no tool available at this point in time. And this is why most of us actually use oxygenation as our guide to monitor lung volume. And this takes a little bit of physiological knowledge, and I'm going to walk you through this to make sure that you all understand how this actually works. So on the left side here, I've drawn one alveolus with the adjacent capillary running by. As you can see, this alveolus is collapsed, so there is no fresh oxygen entering the alveolus. So the blood that is coming from the right side of the heart will actually reach the alveolus, but there is no uptake of oxygen. So the blood flows to the left side of the heart in an hypoxic state. And this is what we call intrapulmonary right to left shunt. We can increase the pressure, and at a certain pressure, critical opening pressure, the alveolus pops open. And this is a quantal behavior. So it's closed and then suddenly it opens up. You get a rapid increase in the volume inside the alveolus. Now you have the optimal VQ match. Now you will see that there is uptake of oxygen in the blood running by this alveolus and going to the left side of the heart. So this is the optimal VQ match. So going from a collapsed state to an open state is what we would call recruitment. We can increase the pressure even more. The volume will certainly increase in the alveolus, but there's no change in the VQ match. So oxygenation will actually remain the same. and this is what we call distension. We can increase the pressure even more, and then we come into a phase which we call overdistension, where the large volume in the alveolus actually compresses the capillary running by. And this is actually the opposite of where we started. This is increased alveolar dead space. So there's ventilation, but no perfusion. So this is one alveolus. If you add them all up, every alveolus has a different opening pressure. You get this typical inflation limb of the pressure volume relationship, where you stepwise, starting on the left lower side, increase the pressure, you measure the lung volume, and slowly you can see the lung volume increase. A flat part in the beginning, steep part in the middle, and once you reach total lung capacity, again, the inflation curve flattens out, which means that by increasing your pressure, you actually gain not much of volume anymore, because you have opened all the alveoli and you're reaching total lung capacity. If you would measure the blood that is flowing into the lungs from the right side of the heart, and you would then determine which percentage of the blood flowing into the lung will flow to collapsed lung units, we call this the shunt fraction. You, of course, in the beginning, when you start lung recruitment, the shunt fraction will be high because most of the alveoli are still collapsed. You will need 100% of oxygen to actually get some decent oxygenation. But as you start recruiting the lung and lung volume increases as you increase the area pressure, alveoli start to pop open, your VQ match will improve. This will improve also your oxygenation, and you will be able to wean down your FiO2. And if you have fully recruited the lung, theoretically, if this is the only issue inside the lung causing cyanosis, then you could actually ventilate a baby in room air, an FiO2 of 0.21, if the lung is fully recruited and the shunt fraction is below 10%. An important law we need to take into consideration is the law of Laplace, which states that the pressure you need to open up or keep an alveolus open is 2 times the surface tension divided by the radius. And the radius is where it gets really interesting, because it means that if you recruit the lung, if you recruit the alveolus, the radius will suddenly increase. And as the radius increases, it means that the pressure you need to keep an alveolus open will be much lower. So in fact, what you see based on Laplace is that in the beginning, when the lung is collapsed, the alveoli is collapsed with a very small radius, you will need a high pressure to open it up. But as soon as it pops open, the radius increases significantly, and the pressure to stabilize the alveolus will be much lower. And this is why if you walk up the inflation limb indicated in yellow and you start reducing your pressures step by step going down, you will initially have a lot of lung volume remaining despite the fact that you are actually reducing the pressures. And this is what we call lung hysteresis. If you look at the shunt fraction, going now from an open state and moving down the deflation limb, actually you will see that the shunt fraction and thereby the oxygenation will remain stable for a longer time than during the inflation limb. And you will actually can keep the FiO2 low until a certain point in time where the pressure becomes too low and some of the thickest alveoli start to collapse, and your VQ match will be reduced, and you will get more hypoxemia in these babies. So to illustrate this again, this is a piglet lung, surfactant deficient. We start increasing the pressure, not much is happening. Now we can clearly see there is an increase in lung volume, and here we have fully recruited the lung. Now we will go down on the deflation limb back to the identical pressures that we used on the inflation pathway. And you can clearly see there is a large difference in lung volume at the same identical pressure in these lungs because of lung hysteresis. And Here on the deflation limb is where we want to ventilate our babies. So you might think this is all very nice, rabbit lungs, piglet lungs, what about real babies? And this is data that we have from our unit where we used electroimpedance tomography, a new tool still largely under research that actually can measure changes in lung aeration, for instance, in preterm babies on high frequency ventilation. And here we actually measured the change in aeration while we were increasing and decreasing the main air pressure during high frequency ventilation. And in these babies with RDS, you can clearly see there's an inflation and deflation limb, pretty similar to the animal lungs, meaning there's lung hysteresis in these babies, which we actually can use to position ventilation on the deflation limb and have the more optimal lung volume at the same pressure. Same goes for bigger babies, term babies with other underlying lung diseases. This is data from David Tingy's group, again with a different technique showing that there was a typical inflation and deflation limb pressure present in these babies, and also considerable hysteresis that we can use when ventilating these babies. So this is the overview of the basic strategy that we use in the Emma Children's Hospital in Amsterdam when we get babies on the oscillator. The oscillation is the primary mode of ventilation in our unit. You can see mean air pressure on the y-axis, the time on the x-axis. We tend to start at a relatively low mean air pressure, 8 or 9 centimeters of water, and then slowly increase the pressure step by step until we reach what we would call the open lung. And this is guided by oxygenation, and it means that you have to have sort of a target FiO2 that you would like to reach, and which defines when you consider the lung to be completely open. Really important, once you've reached the opening of this lung, you need to back down with the pressure over the deflation limb, taking care and advantage of the law of Laplace and the lung hysteresis until you actually see that the oxygenation is deteriorating with a fixed FiO2. This will tell you that some of the sickest alveoli are starting to collapse again and the intrapulmonary shunt is increasing. Once you've determined this closing pressure, you can reopen the lung with the known opening pressure, keep it there for a couple of minutes, and then wean down the pressure in one step to 2 centimeters of water above the closing pressure. This strategy will allow you to individualize lung recruitments. You will actually use the pressure that is needed for this particular baby with his or her underlying lung disease and also the severity of the underlying lung disease. So what would be this ideal target of the FiO2, which you would call or define as the optimal lung volume? Well, as I discussed in my previous slides, if atelectasis is the only problem in terms of oxygenation, then theoretically you could aim for room air to make sure that all atelectasis is resolved. However, this would be pushing it a bit to the edge, and you want to avoid the risk of over-distending some of the more healthiest lung units. So in my units, if there is no PPHN present, and in the baby is mainly has the problem of respiratory distress syndrome, so in the early hours after birth, we would actually aim for 0.3 as the FiO2 to define the open lung. If you have a baby 1-2 weeks old with already developing BPD with more heterogeneous lung disease, you will probably not reach the 0.3 anymore because of the heterogeneity and the difference between the severity of disease in the different lung regions. So we would probably aim for 0.4, although in some babies you will actually still will be able to get to 0.3. If you have PPHN, which means you have extra pulmonary right to left shunt through the PDA or through the OFO, then of course you need to keep your FiO2 high, and you just aim for the optimal PaO2 in these babies. You will not wean the FiO2 and thereby triggering a PPHN crisis. It's really important to realize that in some babies, you will not reach this target. You will actually increase the pressure until you do not see any improvement anymore after a couple of pressure steps. And this is where you stop and you actually accept that for this baby, this is the best you could do in terms of the FiO2. What about the pressure steps themselves? Well, in RDS, we know that we usually take pressure steps of 2 centimeters of water, and we wait for 2 to 3 minutes at least to see what the effect on oxygenation is. We know that RDS is a homogeneous lung disease where the lung actually has a short time constant. So the effect of a pressure steps you will see within 2 to 3 minutes. On the other hand, if you have a baby with BPD, more heterogeneous lung disease, it may take up to 10 or 15 minutes before you can see the full effect of your pressure step on lung recruitment and thus oxygenation. And to keep it practical, we would take bigger pressure steps in these babies of about 2 to 3 centimeters of water. If you have a baby with meconium aspiration syndrome, and you've stepwise increased your Minerva pressure to about 20 centimeters of water, we would then sometimes use what we call sustained inflations, where we, for 20, 30 seconds, increase the pressure up to 25, 30, or even 35, and then moving back to 20 centimeters of water, trying to limit the high pressures induced to the lung as short as possible. This is what we typically see if we use oxygenation as a guide to lung recruitment. Now you can see on the y-axis, not lung volume, but oxygenation expressed as the SpO2 FiO2 ratio. And on the x-axis, you can see the pressure. You can see you increase your pressure starting in the inflation limb, and you see there's an increase in oxygenation step by step. Once you've reached your target, you go down with the pressure, you have a stable oxygenation, and then at a certain point in time, you see a drop-off in the SpO2 FiO2 ratio, indicating that you are losing some of the lung volume by alveolar collapse. So what kind of pressures would you actually need? So this is data from our unit already a couple of years ago, and these are all babies with RDS. So it's a cohort of 100 babies, where we actually looked at the different time points in the recruitment strategy. So start of recruitment, when you reach the opening pressure, when you reach the closing pressure, and when you reach the optimal pressure for this baby. Blue indicates the Minerva pressure, and yellow indicates the FiO2. You can see we start with a low Minerva pressure of 8. At that time, 70% of oxygen, because we have still a lot of atelectasis. On average, the opening pressure was 21 centimeters of water, and the FiO2 could be reduced to 24%. Closing was 12, and the optimal pressure was 14, indicating the lung hysteresis that I explained to you in some of the previous slides. What about other settings we use? Usually we have a frequency between 8 and 15 hertz, depending on the baby, the underlying lung disease. The amplitude we set, it depends on your ventilator. So if you don't have a ventilator that accurately measures the oscillatory volumes at the Y-piece, you would aim for a slight visual wiggle of the chest. But most of the modern ventilators now allow you to actually measure the oscillatory tidal volume, and we would probably aim for somewhere between 1.5 and 2 mL per kilo. And you want to see spontaneous breathing. Don't forget that the baby actually contributes to CO2 clearance with spontaneous breathing. And if the baby is spontaneously breathing, then there's the likelihood of that the baby is being hypocapnic is very small. IE ratios, again, depending on your ventilator, between 1 to 2 or 1 to 1. Problems that we see, well, head positioning is important, especially in the tiny babies, because if the tube is pushed against the wall of the trachea, you will get damping of the amplitude, so it'll give you hypercapnia. Overdistension is also something to look for. The first sign of overdistension is not so much hypoxemia, but it's hypercapnia. It's the increase in alveolar dead space. If you see a low blood pressure, then you are seriously overdistending this lung. And again, hypocapnia is an issue we should be aware of. So you need to monitor this. So all our babies are monitored with transcutaneous CO2. Like I mentioned before, we want to see spontaneous breathing. And of course, volume guarantee can also play a role. But Manuel will have a look at this in his talk. So one of the key questions is this strategy, this physiology also resulting in better outcomes in our babies? And this is the meta-analysis you probably all know on the trials that compared conventional ventilation to high-frequency ventilation in babies with respiratory distress syndrome. There is a significant reduction in BPD and death or BPD in favor of high frequency with a modest clinical relevance of with an NNT between 20 and 25. There's still some risk of air leaks, especially if you look at the earlier trials. Now, despite the fact that you have this significant improvement, the evidence is weakened or downgraded by the fact there was a heterogeneous effect across the trials, which means that in some trials, there was no difference between conventional and high-frequency ventilation, while in other trials, high-frequency reduced death or BPD. So you can say, well, okay, it doesn't work, there's no clinical benefit. I would like to think that we can actually learn from the heterogeneity. Why are some trials don't find a positive effect and others do? And to me, this is nicely illustrated by the two biggest, most recent randomized controlled trials out there. On the left side, the trial in the US by Sherry Courtney, which actually found a reduction in the outcome death or BPD with a number to treat of 10 in favor of high frequency. And on the right side, the Johnson trial, the UCOS trial done in the UK, where there actually was no difference in the primary outcome death or BPD. So what can we learn from these trials? Well, if you look at these trials, they both included a large number of babies, and babies that end up in a ventilator also in our units. So a gestational age on average of 26 weeks. There was a difference, however, in the underlying lung disease, because in the US trial, only infants could be included if they had severe RDS, while in the Johnson trial, all babies could be included as soon as possible after birth. There was a difference in the ventilators that were used, although I'm not really sure if this actually had a big effect. And finally, in the Courtney trial, you actually remained on the assigned mode until you were extubated. If you were reintubated, again, you received only the assigned mode of the trial, which means that babies that were randomized to high frequency remained on high frequency every time they were ventilated and up to the time they were extubated. In the UCOS trial, if you read the paper, the majority of the babies were actually switched back from high frequency ventilation to conventional ventilation within the first 3 to 5 days. And to me, this could be one of the important messages. High frequency might have a benefit in the babies with more severe RDS. And if you want to have a benefit, you need to keep the baby on the oscillator the entire time so you don't switch back to conventional ventilation. So what about high frequency and the strategy that we use in non-recruitable lung disease? Well, this is completely different in terms that you do not recruit collapsed alveoli. And so many people think of high frequency equals lung recruitment. Well, not in the case where you have non-recruitable lung disease and your main goal is to avoid overdistension and air leaks. So avoid overdistension is your main goal. Use high frequency to get normal capnia, but with using the very small oscillatory tidal volumes. Remember that hypoxemia, oxygenation is a guide, but hypoxemia with babies with for instance, lung hypoplasia, there's always a lot of PPHN involved, which makes it an unreliable marker for lung recruitment in these babies. We use more chest x-rays to assess the FRC because oxygenation is unreliable, and we would avoid any recruitment maneuvers above a mean airway pressure of 15 or even lower if possible. Because if you don't, you will get into trouble in these babies. And to illustrate this is the Vici trial. I'm not sure if you have heard of this trial. This is a trial that randomized babies with congenital diaphragmatic hernia, so to me, a non-recruitable lung disease, to either high-frequency ventilation or conventional ventilation. And what they show that if you look at the comparison between high-frequency and conventional, the babies in high-frequency had a longer length of stay, more often needing ECMO, more often having treatment failure, more use of inotropes, inhaled nitric oxide, sildenafil, etc. So they were clearly were doing worse than the babies with conventional. And the conclusion was in this trial, there is no benefit of high frequency in babies with CDH, and it potentially can do harm. But if you look at the strategy that was used in the babies with high frequency ventilation, the method section, you can see they actually recruited the lung with relatively high mean airway pressures in the babies with CDH. And this will undoubtedly result in overdistension, higher pulmonary vascular resistance, more need of inotropes, more need of inhaled nitric oxide, more need of ECMO. So it illustrates to me we need to understand the underlying pathology and then adapt the actual strategy that we use with high frequency ventilation. Finally, a brief words on weaning and extubation, because I mentioned in the beginning, high frequency is not just, or the lung protective strategy with high frequency is not just using high frequency to minimize lung injury, but it's also aiming to extubate the baby as soon as possible. So there are different approaches on how you should wean and extubate with high frequency ventilation. You could switch to conventional after the acute phase and then wean and extubate from conventional. There is some old data, not very strong, but it's there, that it might not be ideal to prevent VILI and BPD, because you want to avoid conventional ventilation in these babies as much as possible. And we like to wean and extubate directly from high frequency ventilation in our unit. So what's the protocol on weaning and extubation as we use it in Amsterdam? We always aim for the lowest possible pressure amplitude or pressure, mean airway pressure, to maintain the optimal lung volume. If a baby is stable on a relatively high mean airway pressure, even if the FiO2 is below 30%, we would then actively try to reduce the pressure to see if this is still the lowest possible pressure to actually stabilize the lung volume. So every 12 to 24 hours, we would find the lowest pressure in these babies. We would reduce delta pressure, aiming for a CO2 between 6 and 8 kilopascal. So you need to multiply this by 7.5 if you want to have this in millimeters of mercury. And of course, we want to have spontaneous breathing. So in the babies with RDS, let's say the babies within the first days of life, you can extubate when the CDP is below 8 and the FiO2 is below 0.3. However, if you use high frequency in the second and third week of life in babies with heterogeneous lung disease, you can actually extubate from higher settings. You probably will not be able to reach a mean airway pressure of 8 and an FiO2 of 0.3. So typical settings that we would extubate a baby from is a mean airway pressure of 11 or 12 with an FiO2 of 40%. Does it work? This is just a study we did many years ago where we looked at the RDS babies in our cohort and looking at what were the settings on the left side at the time of extubation, directly from high frequency ventilation. You can see there's a mean airway pressure of 7 or 8 and an FiO2 below 30%. And on the right side, you can see that in these babies, about 80 to 90% were successfully extubated directly from high frequency ventilation to nasal CPAP. So to summarize, understand the basic principles of high frequency ventilation, understand the physiology of the lung. High frequency can be used with different pathologies, but this requires different strategies. It might be beneficial in preterm infant with severe RDS and use an individual dynamic approach when you use high frequency ventilation. And still, if you have a baby on a ventilator, even if it's high frequency, aggressive weaning and extubating back to nasal CPAP is really important also. Thank you very much for your attention.
Thank you so much, Dr. Anton, and a very interesting presentation. Dr. Sajjad, do you want to take the questions? There are no questions in the chat box. Do you have any questions?
Yeah, if anybody has any question, but let me first say a lot of thanks to Dr. Anton for his excellent presentation and a very, very clear concept he has given to us in the use of high frequency ventilation. So any questions from any of the participants?
Yeah.
Dr. Junaid has a question.
Please.
Yes,
Dr. Junaid.
I don't know how much time Dr. Anton or Van Kaam had. I have 3-4 questions actually. The first one, when you start from the end, that weaning. So you talk about the pressure, you talk about the amplitude. What about the hertz? Let's say if the baby was sick initially and the hertz was 6 or 8. So can we wean a little bit, increasing the hertz according to our PCO2 to maintain it? It is a very common question many of the participants ask.
Yes, it's a really good question. So usually in the babies that are treated with high frequency, they are actually on 10 hertz or higher in the unit. So we would not increase the frequency in these babies. We just keep the babies on the frequency of 10 hertz or higher, and just wean them on the amplitude, and especially on the mean airway pressure and the FiO2, and then actually extubate them from these settings. If you have a baby with more complex lung disease and where you need to drop down in your frequency to 7 or 8 hertz, usually when the baby recovers over time, it allows you to actually increase your frequency back to 10 or more. And then once again, if you can wean down your mean airway pressure and your FiO2, you can actually extubate again from high frequency to CPAP.
Yeah, so we are also doing, we are not shifting to the conventional, we are going to the CPAP or NIPPV in many of the cases. The other question is, what about the you mentioned about one of your slide about the higher pressure, the lung recruitment strategy. So many times people use a lot of pressure to recruit, and instead of getting benefit, they can get a pneumothorax or air leak. As you said, that the air leak can happen because there is, in one of the studies you showed the meta-analysis, the air leaks favor the conventional. So what do you, is there any limit you want to tell every one of us that much pressure you can use?
Well, actually, there is no limit in terms of a number where you should not go above. It really depends on the underlying lung disease and especially the severity of the underlying lung disease. However, if you use the step-by-step approach that I explained, there is a safety valve in there. In our unit, we decided that if you take 3 steps of 2 centimeters of water, so a total of 6 centimeters of water, and you don't see any improvement in oxygenation, then you stop. You take a chest X-ray and you see what's going on. Are these white lungs? Are these black lungs? Is there PPHN, pre-ductal measurement, post-ductal measurement? So you try to find out why isn't it working in a baby where I would expect an increase in steps of 6 centimeters of water total, that you actually would have some benefit. But there are preterm babies that need a mean airway pressure of 25 or 26 to open up. But there are also babies that only need 12 or 13 centimeters to open up. As long as you individualize and you stop when you don't see a benefit in oxygenation. We published on this in the European Journal of Pediatrics, where we also looked at all the chest X-rays, and we didn't see any increase in air leaks when applying this strategy that we do in Amsterdam.
Yeah, my last question is about the continue on high frequency, not to switch back to conventional and then high frequency, because this is commonly happen in many of the units that, oh, the high frequency is not supporting, not improving the baby, put him on conventional. Oh, oxygenation is not improved, put him on high frequency. It is a very common practice. So can you just emphasize on that point also again?
Yeah, well, to me, high frequency ventilation is a preventive treatment. And that's really important to understand. It's the same as with surfactant. You don't wait 12 hours before you give surfactant, because you know the earlier you give surfactant in the best condition of the lung with no protein leakage, it will work the best. It's the same with high frequency. So I would suggest, if you have a baby and you are considering high frequency, start early on. We decided to just start with high frequency anyway, leave the conventional out there. I don't think it's really necessary. Many babies can actually be managed on conventional, give surfactants, extubate, and they do fine. But as soon as you see this baby is going to take prolonged ventilation, start early. If you destroy the lung with conventional, don't expect high frequency to solve the problem, right? It can still give you some better gas exchange, but don't expect it to heal the lung.
And last one, I'm sorry, other panelists, the INO plus high frequency, it is must, or we can go by the conventional?
Well, if you get the basic idea is that if you recruit with high frequency and you optimize the FRC, then the inhaled nitric oxide will actually reach a lot of pulmonary vessels adjacent to open lung units. If you can open up the lung with high PEEP levels of conventional, it's probably has the same result. But if people are more comfortable with recruitment with high frequency, then I would suggest to combine the two.
Yeah. Thank you. Thank you, Dr. Sajjad.
Thank you very much, Dr. Junaid. Can I also ask one last question from Dr. Anton? As you mentioned, we can directly change or extubate from high frequency to CPAP. So that's what we tend to do as well. So what is the lowest pressures and amplitude would you like to see before you change to conventional CPAP?
So, like I mentioned in the preterm baby with RDS, if this is the baby you were ventilating, probably somewhere with a minimum air pressure of 8 or 9, with an FI 2.3, maybe below, you can actually extubate this baby to nasal CPAP. We actually don't look that much on the amplitude unless it's really higher than what we normally expect, because there's a lot of variation with the amplitude between these babies. If the baby has been treated with surfactant and is doing well, and you would expect the baby to be in a better condition, then we just extubate them. In bigger babies, we would probably want to see the amplitude, depending on the device, of course, that you have, because amplitude is not the same across all the devices that we have. But with the Sensomedics, we would probably around 20 would be okay, or below, and then we would extubate the baby to nasal CPAP.
Thank you very much. I think there are some other questions from the participants.
We have question answer session in the end, and Dr. Anton has to leave, but we'll have one more question, and then we will move on to the next session when Dr. Sajjad will introduce Dr. Junaid, and then Dr. Junaid will proceed. So one final question for Dr. Anton, and then we will move to the next session. Thank you so much, Dr. Anton, for joining us.
So are you going to put the question, Sardar?
No, you had some questions, so you can select one of them.
No, you select one because I cannot see them here in the sequence.
Most of the questions are centered around the recruitment strategy. You have done a lot of original work on animal models as well as in babies, and you're doing it very well in your unit yourself. So Can you briefly outline the recruitment strategy? One of them has asked about starting with 8 centimeter water, which is what, I mean, I don't think you'd start recruitment at 8 in clinical settings. Mostly you'd be on 12 to 14 MAP. So starting with that, and FiO2 what the baby clinically needs. So please give an example to illustrate this, and then we will close this session.
So I think it's really important if you're using high frequency as an early rescue, with the emphasis on early, but your baby is already unconventional, then we know this rule, mean airway pressure conventional +2, is where you should start with your mean airway pressure on high frequency ventilation. And I understand this is out there and there's some rationale for this. To me, the problem is that if you use this mean airway pressure +2, you have the risk of flying in somewhere in between. And if it doesn't go well with the baby's not responding, where do you need to go? Do we need to go up? Maybe too high? Do we need to go down? It's always an issue. So I am more in favor of starting at a lower mean airway pressure, much lower than the mean airway pressure +2 conventional. And the reason is that if you start low, in some babies, they actually don't need a lot of pressure. And you have the risk of overdistending if you're flying at mean airway pressure +2. If you start low and the baby is deteriorating, oxygenation is falling, there's only one way to go, and that's up. You don't have this issue of overdistension. And then you can actually increase your mean airway pressure, maybe not in a step of 2, but even at 4 centimeters of water, making sure that you actually get a recruitment procedure and your oxygenation is improving. So for us, we are always starting with primary high frequency. So there is no conventional mean airway pressure that we can use. And that's why we actually start with the 8 centimeters of water in most of the babies and then titrate up. Again, there's only one way to go, and it's up if things are not moving in the right direction in the baby.
Thank you so much.
I think we will close the discussion here. Thank you very much, Dr. Anton, for your very nice explanations to all the questions. It was a great learning session for all of us.
Yeah.
And let me say, I learned a lot from your presentation today. Thank you very much.
Okay, my pleasure.
So, thank you very much. Bye-bye. Our next speaker is Dr. Junaid Mohib Khan.
Next moderator.
He's a well-known. He's a moderator, sorry. But he's presenting as well. Or not?
No, not today.
Not today. Okay. So please. Yes, me, Junaid.
Okay. So thank you very much, Dr. Siddharth, and thank you, the organizers, Rajiv, my old friend, and Sridhar. It's my pleasure to introduce Dr. Manuel Sanchez, is the medical director of the Neonatology division at Hospital General University in Spain, in Madrid, Spain. The capital city of the Spain is a beautiful city. I was there and I saw the bullfighting there. Okay, man. And also currently is the chair of neonatal critical care section of the European Society of Pediatrics and the president of the Spanish National Society of the Neonatology. Areas of interest is the lung protection, which we are talking today, of lung protection of immature infants and personalized nutrition. Dr. Sanchez is very well known in our region in UAE. He visited us and also in our hot topics of neonatology conference in Abu Dhabi. So he's going to talk about a little bit, new topic, the high frequency plus volume guarantee to prevent lung damage. The screen is yours, Dr. Sanchez.
So many thanks. First of all, I would like to see if everything is working well and you can see my screen.
Sure.
Is this okay, Jeanette?
Yes.
Okay, thank you. Well, many thanks for your kind introduction and many thanks to the organizer for inviting me and giving me the possibility to introduce this topic. This is a topic where we have been working more than 10 years from now. A very new topic about high frequency ventilation. So first of all, I would like to review some of the data that previously Dr. Anton has review about the possibility of using high-frequency ventilation from the beginning to decrease the damage to the immature lung. When he was reviewing the topic, he reviewed and introduced this Cochrane review done by my good friend Philip Kurtz some years ago. With this Cochrane review, with this meta-analysis, the evidence about the possibility that using from the very beginning high frequency instead of conventional ventilation to treat very immature babies, decreasing BPD or improving survival of the babies was not proven. But he said there was 2 big trials, the Corney trial done in the United States and at the same time, the UK trial. The 2 trials were different. In the first trial, as Dr. Anton van Kaam said, babies were doing much better with the high frequency ventilation. And in the UK trial, babies were doing exactly the same, compare the 2 strategies, conventional to high frequency ventilation. But look, the 2 trials were done in 2002. So more than 20 years ago, where devices were absolutely different compared than today. Devices were not clearly developed for immature babies or premature babies. So devices were producing a very large tidal volume during high frequency ventilation. And probably those devices were not well controlling this large tidal volume produced during high frequency ventilation. One of the good things is that the investigators of the UK trial, they followed the babies who were included in the study after 14 years. And they found something very important for us. They saw that babies in the group of high frequency ventilation compared to those in the conventional were doing better after 14 years in terms of the pulmonary function test. So this gave to us in our group the idea that something was not very clearly related to the benefits or not at the very beginning, but in the follow-up of the babies. Babies on the high frequency ventilation were doing better, giving to us the idea that probably the high frequency ventilator were probably producing less damage into the baby's lung. Well, in this trial, in the UK trial, unfortunately, today we don't have this hard copy table that was published only in the internet, but there was this very important table for me that when babies were compared, depending on the type of the ventilator used in this UK trial, they saw that when they were using this very potent ventilator sensor medics, babies were doing worse in terms of higher risk of dying or developing chronic lung disease compared to those other babies who were using this other ventilator. Which is the main difference between the 2? Well, by those years, 20 years ago, the most important difference was that the power for the ventilator was lower with the drier one, and the tidal volumes that was produced during high frequency ventilation by this ventilator was smaller. So we kept this in our mind, and we began to think the possibility that probably there was some hidden effect of high frequency not seen before, reducing this damage into the lungs. And because we were working many years with the volume guarantee modality during conventional ventilation, when this modality appears combined to the high frequency ventilation, we began to think that probably we could use this new modality to prevent the development of very large tidal volume during high frequency ventilation. For those who are not familiarized with the volume guarantee strategy, this strategy has been demonstrated for more than 30 years that it's a very safe strategy, decreasing the damage into the lung of the ventilated babies, because you are sending a very well-controlled tidal volume every cycle. What is the ventilator doing? The ventilator is working in a continuous flow with pressure-regulated control, and the ventilator moves the pressure up or down, the peak expiratory pressure, to shed exactly a very similar tidal volume that you're setting to the ventilator. So what the ventilator is doing is decrease the variability of the tidal volume cycle by cycle, and it's adapting to the lung compliance situation of the baby's lung to send exactly the tidal volume that you are setting. With this philosophy in mind, then the high frequency ventilator can work also with this strategy of volume guarantee. Well, the ventilator is set to send a very close to the setting tidal volume produced during high frequency by going up or down in the amplitude of the ventilator. So you don't have to move the amplitude of the ventilator. The only thing you have to do is to set the frequency number 1, mean over pressure number 2, and then the tidal volume directly to put exactly the lung of the baby in the situation where you want to be during high frequency. Then the ventilator, what it's doing is to modify the amplitude cycle by cycle to set exactly the tidal volume that you want. So here you have in our lab 2 different colors of how the tidal volume is produced depending on the frequency and the tidal volume. So with a classic ventilator without the volume guarantee modality, you have to remember when you increase the frequency of the ventilator in hertz, then the ventilator decreases the tidal volume because the timing to send the tidal volume is lower and this tidal volume is lower. So this is why when for many years you wanted to increase the CO2 washout, you used to decrease the frequency of your high frequency ventilator because then you have this increase in the tidal volume, and this increase in the tidal volume is going to produce this increased amount of CO2 washout. So this is the very first study published in 2013, 10 years ago, in our animal lab, where we test the hypothesis that using this high frequency volume guarantee modality, you can set directly the tidal volume to modify the CO2, the PCO2 in the patient, or in this case, in an animal. Well, this study was done in an animal neonatal model, piglets, 1 to 2 days of age in the standard physiological condition, and after decreasing the compliance of the lung by taking out all of the surfactant by bronchoalveolar lavage with saline. So in this situation, you can see this is the PCO2 of the normal lung situation. This animal was ventilated on high frequency at a constant rate of 10 hertz, and then we increased the tidal volume from 2 to 2.5 and 3 ml per kilogram of body weight, and you can see how the PCO2 decreases automatically in a very similar way. So then we put the situation of the animal lung in the low compliance by taking out the surfactant by this bronchoalveolar lavage, and you can see how the ventilator kept the PCO2 in the same condition as before, keeping this tidal volume set at 3 ml by kilogram of body weight. So this is the very first study published with this new modality of high frequency, demonstrated that today we can directly set the tidal volume instead of modifying delta P, as it was done before to control the PCO2. So what is the ventilator doing with this in this strategy? As you can see here, this is the same study. Anytime you increase the tidal volume, this is amplitude of the ventilator is increasing the amplitude to reach the tidal volume that you are setting. And this is the before and after. The ventilator, what it's doing is to modify delta P to keep exactly the same tidal volume that you are setting by the ventilator. Well, more studies were done trying to demonstrate the benefits or the efficacy of this new strategy. And this other trial that we published 1 year after, we produced this testing lung with different strategy. Instead of using live animals, we produced this continuous CO2 into the testing lung. We analyzed by a computer the power of the ventilator clearing this CO2, and we wanted to know exactly what was happening with delta P proximal right in the middle and inside the testing lung to know if this pressure was or not transmitted into the lung of a baby. Well, with this testing lung, with this experiment, we demonstrated again that every time you modify the frequency, when you're using the new strategy, this is the dark point volume guarantee modality, you can see how the effect on this CO2, what is the way that we control and we analyze how much CO2 is taken out from the lung. You can see how anytime you keep the tidal volume fixed, if you modify then the frequency, because the tidal volume is fixed, then the effect on this CO2 is higher. And remember that without the volume guarantee strategy, with the standard ventilator on high frequency, when you increase the frequency, then the effectivity of the ventilator to produce this clearance in the CO2 decreases. So for the very first time, we demonstrated that now you fix the tidal volume, you can go up and down with the frequency, and you're going to wash out exactly in the same way as in conventional ventilation, the CO2. But important for us was to know what was happening in the pressures. Delta P in proximal, right, in the tracheal tube or inside the testing lung, and in 3 different colors, you can see the proximal. This is in the white color. The green one is around in the tracheal tube, and this purple color is inside the lung. And as you can see, if you fix the tidal volume, but you increase the frequency from 5 until 10, and then 20, the proximal pressure increases, delta P increases to maintain the tidal volume, but this pressure is not transmitted into the lung of this testing lung. So this demonstrated that this strategy is very safe in terms that you can modify delta P, but delta P is damped and it's not transmitted into the lung of the baby or the animal. And you can see in different colors now, the blue color represents the proximal pressure, and this other color represents inside the lung. When you are using this volume guarantee strategy and you increase the frequency, you have only this increase in the proximal pressure, but this pressure is not transmitted into the lung. Without this modality, using the standard high frequency ventilation, anytime you modify the frequency, the pressure drops very fast. And this is why during many years, many ventilators were setting with low frequencies. Because when you go very high in the frequencies, higher than 15, most of the ventilator will drop the pressure into the lung of the baby. Probably this is why for many years, the setting in the high frequency ventilator was around or between 10 and 15. Well, we wanted to test a new hypothesis. We were thinking now, if we know that the tidal volume really represents one of the most important etiology of the ventilator-induced lung trauma, then if we could use very, very low tidal volume, but compensating the ventilation, increasing very high the frequency, then we probably can decrease the damage into the lung using this new strategy. So this was the very first study that we did and published in 2019, comparing two randomized strategies in our animal model with a surfactant in a low compliance situation. We compared 2 strategies, the standard 10 hertz with normal standard tidal volume and high frequency ventilation during 12 hours, compared with another group of animals where in a randomized mode, we use 20 hertz with very low tidal volumes. Exactly the same CO2 in both of the animals, exactly the same mean airway pressure, but tidal volumes were very low in this 20 hertz group of animals. So after 12 hours, we analyzed the effect on the histology of the lung, and we could see that in the group of animals where the 10 hertz with the standard tidal volume of high frequency was used, the lung histology represents a very high damage of the ventilator, producing inflammation and rupture of the air spaces of the lung. But in the group of animals where the 20 hertz strategy was used with the very low tidal volumes, the histology of the lung was spur. Lungs were very well in terms of not very high inflammation, not rupture of the lung spaces. And if we apply a score and compare with another group of animals where the conventional ventilation was used at the same time, using this score, the higher is the score, the higher is the damage into the lungs. You can see how the group of animals with the higher frequency and lower tidal volumes did have a very low score lung damage. So in this study, we demonstrated that using this very low tidal volume with very high frequency, you can decrease the damage into the lung. So I must remember you that today we can control this tidal volume, and we can increase the frequency as much as we want to keep the tidal volume in very low numbers to prevent lung damage into our very immature babies. But can this strategy be applied in premature babies? Well, what we did, and this is the very first study using this strategy in very mature babies that we published in 2016, what we did is to did this feasibility study to know if babies could be ventilated with this very high frequency strategy with very low tidal volumes. What we did, and you can see some of the babies were less than 1,000 grams. We put the babies on this high frequency when babies were having this very severe respiratory distress syndrome in the standard high frequency ventilation around 10 hertz with a standard tidal volume. So after stabilization, then we moved the ventilator to decrease the tidal volume as much as possible. And you can see we go, this is the mean 1.4 of ml per kilogram of body weight, and we increase the frequency very high to compensate the PCO2. And you can see that using this strategy, babies were doing well. FiO2 was exactly the same, very similar. But look at this. This CO2 was the way to analyze how the ventilator is watching the CO2 decreases. And delta P was not statistically significantly higher than before. So the strategy could be used, and even more, babies were doing better in terms that improve their oxygenation and improve the PCO2. So with this in mind, after this feasibility, we began to use this strategy some years ago, and we very recently published this effect. And we analyzed the group of babies where we were using this strategy. Normally, we use this strategy in all of the babies who are now on high frequency ventilation, but the very high frequency and very low tidal volume is mostly used in those babies less than 26 weeks gestation. As you can see here, most of the babies were below 25 weeks gestation. And you can see the characteristics of the babies depending on the frequency that we were using. Babies in the higher rate of frequency around 20 hertz were mostly babies around 500 grams. So the smaller, and 24 weeks gestation, the smaller is the baby, the higher the frequency that we could use, decreasing the tidal volume as much as possible. And as you can see, we switched to the high frequency strategy very early. When the babies were sick enough to need conventional ventilation, I will show you thereafter how we implement the strategy. We switched to high frequency very early as the beginning, as Dr. Anton and Kaam say. We wanted to protect the lung before the conventional ventilation is producing these damages. Which is the frequency, which is the relationship between the frequency and the tidal volume. You can see here with the higher frequency, the lower tidal volume was used. And with the lower frequency around 13, you have higher tidal volume. So this depends many times on the size of the lung of the baby and the dynamic condition of the lungs. So if the baby is very small, you can go to very high frequency. The baby is bigger, than the transmission of the waves, as you know, high frequency is worse, and you need to go with lower frequencies. But look, we saw this, putting together the frequency and the tidal volume relationship, you can see this very funny curve. So the higher is the frequency, the lower is the tidal volume that you can use. So this means that when you go up to around 16, 17, 18, 19, or 20, the efficacy of this very high rate is much higher than when you are in this lower frequency, close to 10. And this is because you reach the resonance frequency where the effect of the high frequency ventilation is much higher. So as you increase the frequency, you can even decrease even more the tidal volume because the efficacy of the ventilation is much higher. So we recently analyzed the effect of this strategy from our babies in a study before and after. Before, we were using high frequency combined with the volume guarantee strategy, but without this new way to protect the land of very high frequencies. And the second cohort were those babies where we were doing this new strategy, where babies were very similar, but we found that using this new strategy, after 2 years of age, babies were doing better in terms of less respiratory therapies and less admission in the hospital because of respiratory problems. So not clear big benefits, but babies were doing better after 2 years. So we also wanted to implement with this new strategy a new way to analyze how the lungs are recruited or not. So we were using for many years the same strategy of Dr. Kaam, using the FiO2 and oxygenation to control how the lung is well recruited. But now we using the high frequency combined to the volume guarantee, we demonstrate that delta P can guide very well this lung recruitment. So we did this study, ex vivo model in the animal lab, and thereafter in vivo model, and we demonstrated that anytime you increase the mean hour pressure, as you can see here, delta P modifies using the volume guarantee strategy. Without the volume guarantee, you can't do this, but you can see that you combine delta with mean hour pressure. As you increase mean hour pressure, there is a point where delta P do not decrease even more. Well, this point represents the open lung before overdistation. So if you see that there is no any other decrease in delta P after increasing mean hour pressure, then this area, the only thing that you are going to have is overdistation. Why? We wanted to test this new strategy because in some babies, oxygenation is not the better way to guide the recruitment. And in this in vivo model in an animal rat, we combine the two strategies, delta P and oxygenation, and you can see how anytime you increase the mean overpressure, there's an increase in the oxygenation until a specific point where no more increase in oxygenation you will reach. And this is exactly the same point where delta P do not decrease even more. So today, what we are using is the two strategy combines together. Well, this is our criteria for using this new modality, this new strategy in babies with severe respiratory failure. We first put the babies on conventional PSV plus volume guarantee, but if the baby is needing more than 15 millibar for peak inspiratory pressure in babies less than 1,000 grams, then we switch very fast to high frequency combined with the volume guarantee modality. Of course, any air leaks in some PVA chain or pulmonary hemorrhage or some other atelectasias or pulmonary hypoplasia, those babies are on high frequency ventilation. So we, and this is my last slide, we wanted to test very recently the effect of this new strategy, and we compared two different cohorts, 2 different periods of using this new strategy in preemie babies less than 32 weeks gestation. And we did this binary logistic regression to put, all confounding variables, and we saw that using this new strategy, we increased survival free of BPD in the babies in a statistically significant way. We also decrease the number of babies who need to be ventilated during the first 3 days after delivery. And this is even more important for us. Look, we decrease in a very statistically significant way the severity of the BPD of those surviving babies. So this means that probably we are in the track decreasing the severity of the ventilation in these very immature babies. And this is my last comment. We recently, just a few weeks ago, published this paper. This is an experimental paper where we analyzed the effect of this new strategy, comparing with or without the volume guarantee in an animal model, the effect of this strategy in cerebral hemodynamics. And we demonstrated that there is no effect in terms of modifying the blood perfusion or oxygenation of the brain. So this is a safe strategy, and at least we found very good results in terms of decreasing severity of lung damage. So thank you very much for your attention. I will be more than happy to answer any kind of question that you have to do right now. Thank you.
Thank you very much, Dr. Janet. Can I ask a question with your permission?
Oh, yes.
Dr. Janet.
Oh.
Yeah, please proceed, Dr. Sanchez.
Yes.
Yeah, thank you very much. It was excellent presentation. Congratulations on that. My question is, do we have enough evidence to say that at this stage, we have enough evidence to say that high frequency with volume guarantee is better than conventional ventilation with volume guarantee?
Well, this is a good question, but it represents that we have exactly the same question with or without volume guarantee. So if you ask to Dr. Anton that high frequency is not better or is better than conventional ventilation, the answer is we need to do randomized controlled trials, probably again, with new ventilators using this very well controlling tidal volumes. So today I must say that with this strategy, at least in the animal lab, we found that the lower is the tidal volume, the better for the immature lungs in terms of prevention of lung damage. So my answer is today in our animal lab and today in our babies, more than 300 babies ventilated with this strategy. The only thing that we can say is that, number one, this strategy is very safe. And number two, this strategy decreases the damage of the immature lung if you're using it very early. So the idea is that controlling the tidal volume and decreasing the variability of the tidal volume during high frequency ventilation, you will have two advantages. Number one, you will decrease very large tidal volume that for many years, many people were using with those very old ventilators that were using very large tidal volumes. And number two, you will control the variation of the PCO2 that you know that can produce damage into the brain of our babies. So volume guarantee represents a real advance in conventional ventilation because, as you know, there is enough evidence that this strategy decreases not only BPD and increases survival, but also decreases brain hemorrhage. And why not using the same strategy to the high frequency, you will prevent even more damage into the lung of the babies when you compare high frequency with or without volume guarantee.
So
thank you very much.
Yeah, thank you. So the question is that, Dr. Sanchez, in high frequency, I use the word conventional high frequency without volume guarantee. Still, the volume is very low. It's not that much volume the high frequency using. Am I right on that?
Well, it's low or it's high, depending on the baby. You can use half of the standard tidal volume with this volume guarantee modality, and you can fix the tidal volume. So the benefits is that you can fix in these very, very low numbers, and to compensate, you can go very, very high in this in frequency. So remember, for the people who are listening to us, that the tidal volume during high frequency normally is around or less than the dead space. So sometimes many ventilators are used in very large tidal volumes. And as you say, those ventilators, what they are doing is producing tidal ventilation at very high rate. And this is very traumatic. And this is very producing a lot of damage into the lung of the babies. So many people will clearly see that babies are improving very fast using this very large tidal volume. But at the end, what you are doing is producing a lot of damage into the lung.
Yeah, so my question is that let's say we are using the sensor medics, then it's a very difficult for those things because sometimes these are not, I mean, the trigger cannot be very well with the high frequency. So that's how we can, with the sensor medics, is there any strategy which we can use?
Well, we more than 15 years ago, we sell our sensor medics. We never use them again. With the new strategies, we don't have any kind of problems. Number one, you have to remember that the high frequency ventilator is very effective when the lung is very small. If you go up to 5, 10, or 20 kilograms of body weight of a baby, then this strategy doesn't work well. And all of the studies done in adults or bigger babies demonstrated that that strategy is not very effective because of the very large size of the lungs. So when you're using this kind of sensor medics, you have to remember that you don't know exactly how large is the tidal volume, the volume that you're using. And of course, you can go very fast reducing the PCO2, but this is not the idea when you're using high frequency ventilation. The idea is to prevent lung damage of the ventilator. So this new generation of ventilators, in this case, Drager, the one we are using, can ventilate any size of neonates. That is the idea that we are using. Of course, the bigger is the baby, the more difficult to ventilate on a high frequency ventilation. Even with the sensor medics, if you're using this ventilation in babies around 20 kilograms body weight, you have to use 3 hertz because the cloud is not transmitted into the lung. So today we moved to this new idea to protect the lung of the babies.
So one of my friend, he's working in Qatar. He's asking that if we he's working in Sidra Hospital, if we use high frequency plus VG in CDH, congenital diaphragmatic hernia, do you have any say on that, or do you have any comment?
Well, first of all, my greetings to the Qatar Sidra Hospital, good friends.
Yeah.
Well, we use only volume guarantee strategy in all of our babies. Doesn't matter the babies on conventional or in high frequency. You must remember that the volume guarantee modality put the ventilator in the same strategy that before, but the only thing is that then delta P is going to be modified by the ventilator, but not by yourself. This is the only thing. And many times we have some questions coming from all around the world after our studies that sometimes the ventilators are not reaching the tidal volume. Well, the only thing you have to do is to increase delta P. So you have to leave the ventilator to produce this tidal volume that you are setting into the ventilator. And if the ventilator doesn't reach this tidal volume, this is because there is a problem in the lung of the baby, or you have to decrease or modify the frequency. So congenital diaphragmatic hernia is a problem that we used to use very what we call soft ventilation. We use PSV plus volume guarantee in all of the babies, trying to keep the baby ventilated spontaneously and producing by their own the volume, the minute volume. But if the compliance is low, then we switch very fast to the high frequency. All of the babies are on volume guarantee modality. All of the babies.
Yeah. So with the volume guarantee high frequency and the weaning is the same as Dr. Van Kam said, or is any thing different?
Well, exactly the same. The thing is that, number one, you have to remember that if you put the baby, because the baby's lung is having very low compliance, anytime the lung compliance of the baby improves, then PCO2 doesn't remove so well. So when the baby is improving, normally you will see an improvement in the oxygen saturation and not very well ventilation. Then what we try to do is to decrease even more minor pressure until the baby reaches around 5 to 7. Then we try to extubate the baby directly from the high frequency. Normally those babies are around or below 30% oxygen FiO2, but we try to keep the frequency exactly the same in very, very high rates. So tidal volume, we don't decrease anymore. The only thing that we do is we decrease the minor pressure around 5, the baby is very small, or around 7 if the baby is bigger.
So the last thing from...
yes, Dr. Junaid, can I...
Yeah, sure.
Can I ask just one question, if with your permission?
Sure. Go ahead, and then I will ask.
Yeah, Dr. Manuel, what would be the most appropriate starting setting for high frequency with volume guarantee, say in a 1,000 gram baby?
Well, this is a fantastic question. As we published very recently in clinics per neonatology, we are using around 1 ml per kilogram of body weight of the tidal volume and around 15 hertz in those babies around 1,000 grams. Then what we try to do is to look at the PCO2 of the baby, and the baby is doing well. What the thing is, then we decrease even more tidal volume, and we compensate increasing the frequency even more. So we try to go to the higher frequency as possible. If we can reach 10 hertz, then we go to 10 hertz. So this is the idea, to go to the higher rate as possible, decreasing the tidal volume as much as you can. Babies around 1,500 grams, we use 1.5. So it's very similar to the body weight. So around 1,000 grams, 1 ml per kilogram of the weight as a starting setting, and around 15 hertz. And then we try to increase the frequency and decrease the tidal volume as fast as we can.
And what would be the pressures and amplitude?
Well, amplitude, we leave the ventilator to the amplitude. And normally amplitudes, working amplitude is around 15 or 20, not more. But we leave the amplitude to the ventilator to modify, because you need to keep the possibility of the ventilator to go up or less, depending on the situation of the circuit and the lung compliance of the baby. So we don't look at the amplitude, we just control, but we use the ventilator to modify the amplitude as it is needed.
So the
Thank you
last
very
question
much.
which I am asking, thank you, Dr. Saddad. Before Dr. Saddad asked this question, that about the troubleshooting. So let's say you started with the volume guarantee, plus high frequency plus volume guarantee, and the baby is not doing well because of some reason. Okay, so what do you think? You go switch back or increase the volume you are giving more than 1 ml per kg? Let's say he's not maintaining the oxygenation, he's requiring higher FiO2 to maintain 90 and above.
Well, we think twice before doing anything. And number one, we ask why we put this baby on the ventilator. If the baby is having a low compliance situation, then probably we don't have this functional residual capacity reached. And we do this recruitment maneuver looking at delta P. So we switch the middle pressure up, and if the delta P doesn't move, we do not increase anymore the middle pressure, because probably the lung is over-distended, even if the oxygen saturation is low. Then we look at the lung ultrasound, and we look at the cardiac ultrasound as well, because sometimes those babies are having another problem, different problem. And of course, we look at the X-ray. So before doing many things in the ventilator, we test delta P, and then we test the lung with the lung ultrasound, and we test the heart with the heart ultrasound. Sometimes you will find that something is wrong, not with the ventilator, but probably with the lung of the baby.
Thank you.
Okay, so that is from, yes,
I'll
you can go ahead.
Ask a couple of questions before we move to introduce Dr. Dushyan.
No problem.
So thank you, Dr. Manuel, and thank you so much for joining a bit ahead of your scheduled time. Just a couple of questions. One is, what is the sedation policy for these babies? And the second question is related to DCO2. I mean, does it have any role in this volume guarantee mode?
So this is a very good question. Some years ago, we keep those babies too much sedated. So today we leave the babies on very low morphine drip, but we keep the baby awake and breathing spontaneously on high frequency if the baby wants to. As Dr. Van Kamp said, we don't mind if the baby is breathing spontaneously. Even more, the baby is on high frequency, we put the baby on a skin-to-skin care with the mother, even during the first few hours or days during respiratory distress syndrome, and the baby are doing well because we are having the baby on volume guarantee strategy. So when you put the baby, this is very fun. You put the baby on skin-to-skin, and you can see how the ventilator controls and goes up and down delta P, but the volume guarantee modality is kept constant. And the second question, excuse me.
The role of DCO2.
Oh, the role DCO2. Well, what we do is to follow DCO2 after we control the PCO2 of the baby. So we try to do a very first correlation between DCO2 and the PCO2, and then we follow the DCO2. We try to decrease the number of blood gas testing in these babies as much as possible, and we control once a day or twice a day, depending on how sick is the baby. But we follow this DCO2. I think it's a very good way to analyze how the lung of the baby is doing at the beginning. The important thing is every single baby has their own DCO2 correlation with the PCO2. And it is important not to compare DCO2 from one baby to another baby, because this depends many times in the mechanics condition of the lung and the tubing system. So yes, we follow, but we keep this specific DCO2 for a specific baby, individualizing.
Yes, thank you so much. So you titrate it according to the baby. And
yeah.
Dr. Martin, do you have any questions for Dr. Luna before he leaves? No. Okay, thank you so much, Professor Luna, for joining us. And I know you need to leave, so thank you for joining us and have a good evening. Now it's my pleasure to introduce Dr. Dushyan, who will be chairing the next session. And Dr. Dushyant is a consultant neonatologist and lead neonatology at Nottingham University Hospital NHS Trust in UK. So he trained both in India and in UK, and he has published widely. And over to you, Dr. Dushyant. Dr. Martin has already been introduced for his first talk, but if you want to say anything brief about the symposium and about Professor Martin, and then over to Dr. Martin.
Thank you, Dr. Sridhar. It's my honor to introduce Dr. Martin Keszler. Yes, we've heard a lot about Dr. Keszler, and he is an inspirational clinician and a researcher, and kind of a lot of work on volume target ventilation and high frequency has been his pioneering work. So I wouldn't spend a lot of time, but we had opportunity to collaborate with him when we were writing chapters for the book, and he has very kindly peer-reviewed one of our articles as well. So without further ado, I'm conscious that we are running late. I would invite Dr. Keszler to kindly do the concluding talk. And it's been an exciting and learning CME, and it will be amazingly covered by the last talk by Dr. Keszler. Thank you, Dr. Keszler.
Thank you very much for the introduction. And I take it you can all see my screen okay? Can you see my screen? Yes, okay, excellent. So I hope that this talk will actually answer a lot of the questions that are in the chat or in the question and answer session. I will, without further ado, jump in. And so the focus here is going to be talking about the complications and adverse effects of high-frequency ventilation, and to talk about how to avoid those, and a little bit more about volume-targeted high-frequency. So we've made this point before, but it bears repeating because it is so important. Ventilators are tools in our hands. There are no magical ventilators. They're not all, the ventilator itself is not inherently lung protective. Certainly some ventilators are better than other, or can do it better than other, but only if we use them with optimal thought process as to what the underlying disease process is, what size baby, how old the baby, and all the other things. So it is up to us to really understand the underlying concepts. So like anything, high-frequency ventilation has potential complications, and some of those are the same ones that apply to conventional ventilation, of course. And there's been a lot of concern about hemodynamic impairment for high-frequency ventilation. I would argue that that's really preventable. It's not inherent in oscillatory ventilation. And I will explain why I believe that. Respiratory alkalosis has been a recurrent problem, and it is because of the power of the high-frequency devices that we initially used, the sensormedics, for example, but also because of the rapid changes in lung compliance. Of course, that alkalosis is related to brain injury. Air trapping has been a concern, and air leak and potential lung injury have also been problems. Early on, atelectasis was a problem when babies were muscle relaxed and inadequate mean airway pressure was used, but that problem has pretty much resolved. So again, we all have these tools. Some have many of them, some only have one, and we really need to know the limitations and the strengths of our devices and how to optimally put that particular device to work. It is also important to understand how inspiratory-expiratory ratio, or percent inspiratory time, impacts on pressure transmission from the circuit into the baby. And so there is this rule of thumb that you increase the pressure by 2 centimeters with a 1 to, and people don't recognize that that actually only applies when you use a 1:2 IE ratio. And so what this graph shows from an old study by Ulrich Thome is that with a 1:1 ratio, there was not much difference, but if anything, the circuit pressure was a little bit lower than the pressure in the baby. With the 1:2 ratio, there is a gradient, and this has been shown also by Jane Pillow, there is actually a gradient between the circuit and the trachea, and this has to do with the fact that with the asymmetric velocity profile, it takes less pressure to exhale because you have a longer expiratory time. So when you actually, so the measured pressure in the trachea typically is a couple of, mean airway pressure is a couple of centimeters less than what you measure in the circuit. So that actually going up by 2 centimeters merely compensates for that change. This study also looked at other ventilators that were not really true oscillators. The baby log is sort of in between. The infant star very much was not a true oscillator. And you can see there was a lot of air trapping going on in that study, even at low frequencies with the infant star, and certainly when with both devices, the baby log and the infant star, at very high frequencies. So again, knowing the performance characteristics of the device is probably important. This point was made, so the next issue in terms of the optimal lung volume strategy, you saw this graph presented by Anton van Kaam already. And again, it emphasizes that the lung protective effect of high frequency ventilation is related to both the decreased amplitude and tidal volume, but also to optimal lung inflation and even distribution of that tidal volume throughout the lung. When the optimal volume strategy was not utilized, as in this middle graph, you can see that the lungs were quite severely damaged despite the use of high frequency ventilation. So important to always make sure that we do that. And this is just another look at how lung recruitment occurs. And this is now kind of moving. So we're starting with a relatively allostatic lung where there's going to be regional damage to the lungs from regional over expansion. When you're starting on the inflation limb, compliance is poor. You progressively increase stepwise your mean airway pressure, as Anton described, and then eventually you get to when the lung is fully open. And when that happens, you're actually significantly overexpanded in some portions of the lung because there are pressure, there are gradients that are dependent on gravity. So the apical portion of the lung is more compliant than the dependent portion of the lung. So you don't want to stay here because you will have overexpansion. You will have impeded cardiac output. And in the old days of high frequency ventilation, once we recognized the importance of the open lung strategy, the dictum was increase the mean airway pressure. And when you found, quote unquote, the right pressure, stay there. We didn't wean. And that was a mistake because, of course, once the lung opens, the alveoli, the alveolar radius increases, and we know from Laplace's law that the lung becomes more compliant. So you don't want to stay here. It will cause trouble. You need to then slide down the expiratory limb, as he explained, and find the sweet spot just before the closing pressure. And this is where you want to be. You want to be adequately inflated, but not overinflated. So this is important again. And this is what we did for many years. And this is where I think the oscillator acquired a somewhat undeserved reputation for routinely impairing cardiac output. That does not happen when we use the appropriate lung recruitment strategy. I will share with you a little vignette of a clinical scenario that I came across with one of our very good fellows. This was a little 24-week, 600-gram, a very small baby, was status post antinyl steroids and surfactant, was intubated in the delivery room because of the size and inadequate effort. Started on SIPPV or assist control, modest settings. Initially was not oxygenating well, required 100% oxygen. So these low settings were escalated to 24/7, still not extremely high, but the baby continued to not oxygenate well, and was therefore switched to high frequency oscillatory ventilation because that's what we typically do. That's what everybody typically does when oxygenation is a problem. And blood gas was obtained, and it wasn't very good. still requiring 100% oxygen. There's CO2 retention, and there's some base deficit. And so one might wonder what the next step would be. Whoops, this happened too fast. So the tendency, of course, would be to increase the mean airway pressure, maybe increase the amplitude as well because of the CO2 retention. And I use this in many of my talks. And the correct answer is it depends, because we haven't shared all the information. Well, I did inadvertently. So this is actually the X-ray of the baby before initiating oscillatory ventilation. So this was still unconventional ventilation. This baby had no lung disease, or minimal, immature lungs, but already treated with surfactant. So more is not always better. We need to, and this is to Anton van Kaam's point, is if you start too high, you might be overexpanding the lungs. So we need to be careful. And certainly this baby had hemodynamic impairment. That's why there was a base deficit of 9 and an elevated lactate. And indeed, the other point to make is that one of the options was increase amplitude. And I told my fellow, no, actually, you need to decrease the amplitude. After you drop the mean airway pressure by 6 centimeters, you will also be dropping the amplitude because you're now overexpanded. You're on the flat upper portion of the compliance curve, and the lung is now stiff. And the compliance will improve once you deflate the lung, and that's indeed what happens. So this is an important concept, that if we have excessive mean airway pressure, excessive distending pressure, we are going to have multitude of effects. We certainly adversely affect lung compliance. We decrease pulmonary vascular, we decrease pulmonary blood flow because the pulmonary vascular resistance is increased. We also decrease cardiac output because of impeded venous return systemically, and potentially increase the risk of intracranial hemorrhage by impeding venous return from the head. So it's really important that we always seek to find the lowest distending pressure that will maintain lung inflation, but avoid overexpansion. And if we do that, we can avoid these complications. These complications or adverse effects are preventable, but not clinically somewhat challenging. So these two studies have been mentioned a number of times, and everyone has remained quite concerned about why the difference. And I agree with Anton on the point of this last point being really important. In fact, the so-called severe lung disease that he mentioned was these were the thresholds that defined severe RDS. I would argue that's not very severe. So the severity of illness, I don't think, was appreciably different. But what was different was the devices used, the ratio that was used, and probably this was very important, that the babies did not stay on high frequency long enough. But let me again get back to that study by Ulrich Thome, where they demonstrated that with a 50% inspiratory time or 1-to-1 IE ratio, the alveolar pressure was higher. In other words, there was relative air trapping than the pressure measured in the trachea here. With shorter inspiratory time, the usual 1-to-2 or perhaps even 1-to-3 IE ratio, the pressure distally was lower. And this follows from simple fluid mechanics, where if you have an equal time to push gas in as is needed to suck it out, the pressure needed to do that will be the same. If you allow twice as much time to remove that same volume of gas, it will take lower pressure gradient. And so this explains why under many circumstances you can have problems. And then this will be exaggerated if you are not using sufficient distending pressure. If you have relatively low mean airway pressure and you're sucking air out of the airways vigorously, you're going to collapse the small airways and cause air trapping. So this is to the point of some of the problems reported in the meta-analyses regarding air leak. And again, I don't believe air leak is an inherent problem with high-frequency ventilation, but if you're using a 1-to-1 ratio with a low mean airway pressure, as was the case in the HiFi trial I mentioned earlier, then you can cause some serious problems. We're all ganging up on the authors of the Vici trial, but it was a really egregious example of how not to use oscillatory ventilation. And they came up with what I am convinced, and most of us knowledgeable in the field are convinced, was the wrong conclusion. It was, and I'm just showing you some specifics. We know that hypoplastic lungs, hypoplastic lungs should not be aggressively recruited. We know to use a gentle strategy with low end expiratory pressure, and that's what they used in the control arm. However, in the HFOV arm, they used what is a strategy that's appropriate to severe RDS, but is not appropriate here. They started with a mean airway pressure of 13 to 17 and a high amplitude. And not surprisingly, they did not only fail to show benefit of high frequency ventilation, but as Anton explained, all of these adverse effects, which clearly all center around overexpansion of a hypoplastic lung, which we know worsens pulmonary hypertension. So again, it just emphasizes the importance of using the right strategy in a given population. It's a tool that needs to be tailored to the underlying disease. And the underlying disease that best responds to high-frequency ventilation is a disease where the time constants are short. Small babies with RDS. What are time constants, you may ask? Time constants is the concept of how rapidly air gets in and out of the alveoli. So small babies with low compliance and normal airway resistance have very short time constants and are optimal candidates for high-frequency ventilation. Older babies with BPD, I don't ventilate with high frequency. Because they have long time constants and they're not particularly suitable, and there's no demonstrated benefit in that population of HFOV. So when we think about using oscillatory ventilation, we need to, who is your patient? What's the size, postnatal age? What's the disease process? Is it a big baby with meconium aspiration? Long time constants is going to need lower frequencies. Is it a baby? My goodness, my thing is running away for some reason. Certainly, lung volume recruitment is appropriate if we think we're dealing with recruitable lung disease, and you heard all about that. But it's not always the right strategy. Avoiding overexpansion is critical, as I pointed out. And I think what's important to emphasize is that the optimal distending pressure today may not be the optimal distending pressure tomorrow, or not even tonight. So we need to reevaluate. And as Anton pointed out, it's important to attempt to wean the mean airway pressure periodically, at least daily, if not twice a day, in order to get the baby off mechanical ventilation. And by the time the baby's 2 or 3 weeks old and the disease process has evolved away from RDS, I typically switch my babies back to conventional ventilation, all with volume guarantee, of course, because there is, and usually they do better immediately and require less distending pressure when you change to conventional ventilation, because this tool is no longer particularly, meaning the oscillator, is no longer particularly suited for treating babies with evolving chronic lung disease. Again, I already mentioned this: wean, and again, avoid the compromise. So this is some of the generalizable advice that I wanted to address some of the concerns about complications. And everybody used to love the Sensormedics oscillator, but it is an antique. It belongs in a museum, and it was designed for babies with different lung disease, pre-surfactant, effective conventional ventilation, limited use of antenatal steroids. and it has no monitoring. It will tell you what the mean airway pressure in the circuit is, and that's pretty much it. It doesn't provide any patient information. And again, it is very powerful, and we need to remember that, again, it's tidal volume squared, right? So even small changes in tidal volume can result in dramatic changes in CO2 elimination and lead to hyperventilation. And we also need to be aware of the fact that compliance can change quite rapidly in our preterm infants. That is why, and as Manuel emphasized, too much horsepower may not be a good thing. I will give you one egregious example of how high frequency ventilation used the wrong way can cause tremendous damage. This was a study published back in the 1990s using a jet ventilator with the wrong strategy, where tremendous hyperventilation occurred, and predictably there was lots of badness going on with cystic PVL. Death IVH or PVL combined were more than double in the high frequency population. But look what was happening with the pH. So tremendously high PCO2 and I'm sorry, low PCO2 and high pH. So it's important to know that throughout, and I mentioned in my first talk, throughout the history of high frequency ventilation, there are a number of studies that have demonstrated how inadvertent overventilation can occur and how it can lead to very bad outcomes. And this is why I am very excited about high frequency with volume guarantee, because it removes the one major concern that I've had and many have had in terms of using high frequency ventilation with a low threshold or as a first line treatment, because of the risk of overventilation, because they're so powerful, and the consequent adverse effects. So we'll talk. We'll circle back to volume guarantee, but I just want to address the other problem, which was air leak. Which so I think one of the other studies or the data from the same meta-analysis that Manuel showed was any air leak, which included PIE. I focus more on the gross air leak, which is more unequivocal, because I find that PIE is often overdiagnosed. Nonetheless, so in this instance, while the point estimate favors conventional ventilation, gross air leak did not reach statistical significance. But notice that it was really a handful of studies that drove this increased incidence, and that was the study of fluorictome, which was an infant star flow interrupter, and a few other studies. This study was done with the Babylog 8000, a very small number, really. It is probably not, again, inherent to oscillatory ventilation. It does not occur with a 1:2 IE ratio, 30% inspiratory time. And it does not likely occur when we have automatic weaning of pressure amplitude and avoidance of volutrauma from excessive tidal volume when we switch to a volume guarantee. So again, emphasizing, we keep repeating it because it is so important. You need to know your device, know your patient, understand the underlying pathophysiology, and use the right strategy for that particular pathophysiology. Be careful to avoid overexpansion, reassess the distending pressure on a regular basis, and wean when possible to avoid hemodynamic impairment. If you do not have volume guarantee or choose not to use it, always use transcutaneous CO2 monitoring. And even if you're not using volume guarantee, the DCO2 is a proxy of ventilation. It's really a calculated value for CO2 elimination. And you can therefore manually respond to changes in DCO2. But if you use HFOV VG, then the DCO2 will remain constant and you don't need to worry about it and try to respond to it. And I think Manuel has convinced us that we should use the highest feasible frequency to minimize the tidal volume. Now, so in the US, sadly, we don't yet have access to the volume guarantee option of high frequency, but we were able to do a randomized trial. So this is one of several devices that has the capability to use volume guarantee with high frequency ventilation. It's not the only one, but it is the one that I had the opportunity to work with and Manuel works with, and it works very well. And I'll show you briefly some of the advantages. One other thing, we did a small study as a baseline. The noise generated by the sensormatics, is tremendous and goes way up with amplitude. I don't know why my machine jumps forward on its own. The VN500 is much quieter and remains quiet despite increased amplitude. So that's a good thing. Babies, go deaf. And this is a decibel scale. So this is a meaningfully higher baseline noise level. I think Manuel already briefly described how it works. Again, it's very much the same as conventional. Instead of PIP, it's the amplitude that's adjusted automatically. It averages over a few cycles, and you have to set the amplitude limit for safety, just like you set the PIP limit with conventional ventilation. People need to remember that mean airway pressure is still in manual control, so it's not fully automated. You have to pay attention to the distending pressure, but your tidal volumes will stay very much the same. And I think the thing that confuses people most and has been the source of the reluctance on the part of many to adopt volume targeted high frequency is that it behaves differently than what we're all used to. Everybody is used to with VG off that there is this very straight relationship between frequency and tidal volume. At lower frequencies, you get a large tidal volume, and in higher frequencies, the tidal volume goes down. This is from Manuel's work again. And the thing is, who needs tidal volumes of 30 ml? Nobody, not even for your big baby. So when you turn VG on, the closed circles, you will notice that with frequency changes, there's absolutely no change in tidal volume until with this device, you can't at frequency of 15 hertz quite generate a tidal volume of 15 ml. But again, who on earth wants a tidal volume of 15 ml? I don't. So DCO2, of course, is the product of tidal volume squared and frequency. And when tidal volume is fixed, the effect of frequency is now unmasked, and the tidal volume being fixed, the higher frequency gives you higher DCO2, again, until there's a tailing off because the tidal volume drops. So please just think of it simply as the behavior is just like with conventional ventilation. Higher rate eliminates more CO2. That's all. So with high frequency, standard high frequency, it's the opposite. Lower frequency eliminates more CO2. Opposite of conventional ventilation. With volume guarantee high frequency, it behaves like conventional ventilation. You go up on rate, CO2 will drop. Okay. Now, what about the tidal volume? You heard a lot about it from Manuel. And we'll just show you some data we gathered, or I had colleagues, this is from Japan, gather for me because we didn't actually have access to the device. And what's interesting to point out is that for equivalent CO2, you need a somewhat larger tidal volume the smaller the baby is. Just like with conventional ventilation, it has to do with anatomical dead space. So anatomical dead space matters. So at the standard frequencies, we were talking about tidal volumes of about 2 ml per kilo in the 750 to 1000 gram, but the really, really small babies needed, for eucapnia, needed somewhat larger tidal volume, about 2.25, and the bigger babies needed less. This is another data set that looked at tidal volume generation, and you can see obviously frequency has an impact. You need a lower tidal volume for the same CO2 with a higher frequency, but it was also a function of alveolar dead space. The sicker babies with higher oxygen requirement needed a bigger tidal volume. Older babies with evolving chronic lung disease and increasing physiologic dead space also needed a larger tidal volume. And the tiniest babies, this is not a large difference, but it was statistically significant. And there's been a plethora of small studies describing oscillatory ventilation with volume guarantee, but none of these were randomized prospective studies, and they were all quite small, but they cumulatively did suggest that it works and that it is safe. But of course, in the US, we have our Food and Drug Administration, which has to approve a device or methodology. And so in order to try to get that approval to happen, I was able to pull together basically all the folks who've done high-frequency oscillatory ventilation in the US in a major way, in a research way. And we embarked on this prospective study, which aimed to be able to convert a conventional ventilator, which is all we were able to use, to high-frequency ventilation. And we, of course, chose to use the volume guarantee because that is the biggest advance. And we used a prospective, we used a comparison cohort that was prospectively collected just prior to the initiation of this study, because all the larger published studies were almost 20 years old at that time. And so this is a cohort study, not a prospective randomized study, and we weren't happy about that, but that was a decision made by the sponsor of the study and the FDA. So you can see that these were all very immature babies. They tended to be a little more immature. There were more really, really immature babies in that cohort, but they were generally quite comparable. And the primary outcomes of that study were, of course, survival free of severe IVH was the primary outcome. These are the subcategories. And you can see that survival was comparable. The IVH of the lower grades was comparable, a little bit lower. Severe IVH was actually statistically reduced, but this was a non-inferiority study design. And PVL was also lower. So the primary outcome was this life free of severe IVH PVL, which was, to get rid of this if it's shading it, was good, favored the new device was VG. Survival was comparable, etc. This was the one statistically significant difference. And so overall, there was no safety concern. That was, of course, the primary focus. The device worked exactly as planned. And the really tricky and scary part of this study that we had to do was that none of us were allowed to have any prior clinical experience with this device. So everybody's learning curve with this device was included in this study. And despite that, the outcomes were very good. I was very worried about mistakes being made. I just want to show you the CO2 is very stable over a period of time, first 48 hours with relatively tight intervals. Obviously, babies were different sizes, so this is raw data. The tidal volume, and I will tell you that if I did this study today, I would have used at least 15 hertz frequency. We chose to use 10 hertz, so the tidal volumes are larger, obviously, than they would be at 15 hertz. And this was, of course, the study was designed prior to the data that Manuel shared with you. So as I said today, I would be using a lower tidal volume, but the tidal volume, again, was remarkably stable. And there was, interestingly, the same relationship between weight and tidal volume needed for eucapnia in our cohort. Now, this is just to study the babies from my institution, but the same relationship obtained. So it's interesting, despite the differences in the mechanisms of gas exchange, dead space still matters, because the smaller the baby, the larger the flow sensor dead space is relative to the baby. And finally, the last bit I wanted to share with you was, does it actually work as it's supposed to? And I will share with you that the raw data, again, 93% of the time, the tidal volume was within plus or minus 0.1 ml of the target. And 0.1 ml is the maximum resolution. A few were more than 0.1 ml below the target. And in half those instances, the problem was that the clinicians failed to increase the pressure amplitude. They did not allow the device to do what it was trying to do. When we excluded that, did a sensitivity analysis excluding those, it was basically 96% of the time, and very, very few instances where the tidal volume exceeded the target. So this volume guarantee is safe. It works extremely well. It reduces the danger of overventilation and severe brain injury, which is what we all worry about. So as was noted earlier by Dr. Rajiv, that the penetration of volume guarantee seems limited. I see no good reason to not embrace a volume guarantee. I'm still waiting for our Food and Drug Administration to approve this device, but hopefully that will occur soon. So that's all I have, and I'm happy, and I think Dr. Rajiv is also available to answer questions. I'm hopeful that some of these questions will have been answered in the course of this last lecture. So thank you very much for your attention and for the opportunity to talk with you today.
Thank you so much, Dr. Kesler. That is very informative and very pragmatic advice and evidence behind it. I'll kind of hand over back to Dr. Sridhar for the panel discussion.
Thank you very much. I mean, you can go through the chat box as well and bring up questions. Dr. Kesler, one of the questions in the chat box is about how the ventilator regulates the tidal volume. I mean, compared to what the conventional mode regulation does, like breath by breath or 1 or 2 breaths lag. So here, is it time-based? How many breaths does it average?
Oh, okay. So conventionally, it's breath to breath. With high frequency, it's about 5 cycles average. Obviously, at a frequency of 15 hertz, breath to breath control makes no sense.
Thank you. And just
not average. Yeah, but there is a common misconception that the conventional VG averages. It doesn't. It is breath to breath. It's a myth information that Steve Dunn had been spreading for years, but that's not actually how it works.
Thank you. Just a quick clarification. I mean, Dr. Luna had mentioned per kilo of 1 ml, while I mean, your presentation was like 1.9 to 2.3 in that range. Is it because of the different ventilators used, or what ventilator were they using?
Actually, he's using the same devices we were using. Obviously, he was talking about the higher frequencies, but he says he starts at 1. But if you look at the actual data in this publication, it was more than 1. It was closer to 1.5.
Yeah, I think Manuel mentions, yeah.
Yeah, and at the higher frequencies, you probably can ventilate at 1.5. Again, as I said, I would use 15 hertz now if we were doing today. But in our study, one of the reasons we chose 10 was that time constants start to get longer in small babies, even by about a week of age. And by design, as with the Courtney study, we insisted that babies remain on high frequency for 2 weeks. And I didn't want to have to rely on people to remember to decrease the frequency as the time constants got longer. So we kind of started at the lower frequency. I endorse what Manuel discussed in terms of using the highest frequency early on, and of course extubating early. But it's important to understand that as the airway resistance increases and the airway injury occurs within a few days, airway resistance goes up, time constants go up, and you may not be able to use the same very, very high frequencies if the baby now is a week old. So that's a dynamic situation.
Just one more question about the rate, I mean, that is used, the one IE ratio. So you mentioned 1:1 up to 1:3. And is it frequency dependent that you're choosing the ratio in the beginning? Like if you're using a frequency of 15 hertz, what would be your IE ratio?
So I almost always use at least a 1:2 IE ratio. I didn't mention this before, but if you look through the literature, the only randomized controlled trials that showed benefit of oscillatory ventilation used a 1:2 IE ratio. And the air trapping issue is probably real, more so as the baby gets a little bit older. And so it's not a problem under normal circumstances. The question perhaps stems from the fact that some devices, including the VN500, has some limitation of power output because the way it works, it opens all the solenoids and sends a burst of air down the circuit. And there's only so much flow available. So if you have a larger baby where you need a larger tidal volume, 1:1 ratio gives you a little bit longer inspiratory time, so you can deliver a bigger tidal volume. But unless you're really, really pushed, it is, I think, best to use a 1:2 IE ratio, because basically we all ventilate very small babies for the most part, right? And these larger babies that have longer time constants, really it's probably okay to use a little bit lower frequencies, right? We know this. Again, size also impacts time constants. Mice and hummingbirds breathe really fast because their tiny lungs have very short time constants, and whales and elephants breathe really slowly because their humongous lungs take a long time to fill and empty. So the bigger the baby, the longer the time constants, and frequencies need to be responsive to the time constants as well. So when you need a larger tidal volume, you also have a baby who probably is better ventilated with a bit larger, a bit slower frequencies to account.
Yes, I mean, just an extension of the same question, that if you use 1:1 in any situation, you said the map should not be low. Is that right?
No, that is correct, because the way you overcome airway collapse and choke points with active exhalation is you have enough distending pressure that the pressure never becomes negative. But if you have a mean airway pressure of 10 and an amplitude of 30, at the low point, maximum negative deflection, you actually have negative intertracheal pressure, and you are likely to begin to collapse the airway and cause air trapping. So you can mitigate that problem. And in fact, there are some old studies that used very high distending pressures and oscillatory ventilation in patients with bronchiolitis and diseases you would think were not appropriate for high frequency, but they were able to overcome the problem by using mean airway pressures of 25, 30. So it's the choke point, the collapse of the airways, both small and large, are an issue when your distending pressure is relatively low and your amplitude is high and your ratio is 1:1. So that's to be avoided.
Thank you.
Martin,
Yes,
Martin,
Dr.
I want to ask you one very important question, because all over the world, when do you use these hertz of 5 to 7? In which condition do you use such a low hertz in chronic lung disease? And I'm not able to figure out why such the machine becomes extremely powerful at 5 hertz.
Yeah, the machine can generate, I mean, obviously powerful is, I mean, the tidal volume generated is a function of amplitude and frequency. So you can use lower frequency with lower amplitude and not beat up the lung too badly. But when you have high airway resistance, like meconium aspiration or chronic lung disease, you are you have to allow longer inspiratory and expiratory times, hence a lower frequency. So with meconium aspiration, bigger babies, again, have longer time constants, higher wear resistance, longer time constant. So you are more efficient in terms of adequacy of ventilation at these lower frequencies. Those should not be used willy-nilly, but sometimes you cannot achieve adequate ventilation unless you decrease your frequency in these babies. I do not believe that oscillatory ventilation is useful in chronic lung disease. People keep trying it. It keeps not working, but people keep trying it. And that gets back to my point of know your disease, know your ventilator. Conventional ventilation with low rate, high tidal volume is the better strategy for established chronic lung disease.
Yeah. So Dr. Keszler, this is now two extremes, that 15 to 20 hertz or 5 to 6 hertz. Of course, it depends on the baby. But initially, if you said that at 15 to 20 hertz, initially baby has a problem with retention of carbon dioxide. So if we put 15 to 20 hertz, I think it will cause more carbon dioxide retention in high frequency as compared to 10 or 11 hertz or 12 hertz.
So not necessarily, and there are a lot of considerations, including, is the lung overexpanded? Do you have increased alveolar dead space? Is that why your CO2 is high? Maybe you're air trapping. Maybe the lung is over recruited. But the frequency, as long as the concept that Manuel advocates is very sound, the whole concept of high frequency, right, is gentle ventilation, the smallest possible tidal volume. So as long as you can achieve the small tidal volumes without air trapping at the high frequency range, that's fine. If your CO2 is still high, as he pointed out, there is no one tidal volume that is, tidal volume per kilo that's right for every baby. There is as for any physiologic variable, a standard deviation around the mean. We're talking about mean values, but your baby may need a bigger tidal volume. My baby may need a lower tidal volume. They're not all the same. So we have to start somewhere, and this is where the mean values that we talk about are useful. But then you have to look at the response, both in terms of blood gas, but even before you get to the blood gas, you look at the baby. We don't use heavy sedation. We use hardly any sedation in our patients because the patient's response is perhaps even more valuable than the blood gas. And I do not take kindly when my fellows show me a bad blood gas, because I tell them you should have recognized that your baby was not adequately supported. So you don't want the baby overventilated. If the baby becomes apneic, the pH is probably too good. You want the baby to breathe. I want the baby to show me a respiratory drive, and that way I know he's not alkalotic. I don't want the baby to be tachypnic and retracting, because that tells me he's acidotic, and I probably need to increase my tidal volume. So, what Manuel said is he starts at 1, but then he goes up to whatever the baby needs. And typically it ends up being probably close to 1.5 mLs per kilo, which is still below anatomical dead space. So we need to be good clinicians. We need to be at the bedside. We need to look at the baby, not just the blood gas, because there's a lot the baby can tell us if we know how to listen.
Sure. So the other question is related to the same thing, that if the volume, you are putting the volume, let's say 2 ml or 1.5, as you said, and the baby is not improving. So what we can do, of course, we are looking at the baby, we look at everything. The chest X-ray is bad. He requiring more pressure because of the expansion of the lungs are not that great on the chest X-ray. So at that point, it is better to increase the MAP or increase the tidal volume in these babies.
So if the lungs are not well inflated, you're going to have a problem with both oxygenation and ventilation. It's going to it sounds like if we believe this is recruitable lung disease, then we do a lung recruitment maneuver, and it's important that to realize that the lung can de-recruit really fast. If your nurses like to reposition the babies and disconnect them from the ventilator to do that, you can de-recruit the lung in about 4 or 5 seconds. Again, that's a little caveat that it always drives me crazy when the nurses at the bedside don't or doctors for that matter, don't realize how quickly recruitment can be lost. So if you have a poor oxygenation and the lungs looking dense and poorly expanded, clearly you need to do a recruitment maneuver, find the optimal distending pressure. But again, once a lung collapses, it needs more pressure to open than it did before we allowed it to de-recruit, right? So the critical opening pressure is higher than the critical closing pressure. So if we weaned too much, or maybe as a PDA and compliance got worse on account of that, and the lungs collapsed, we may need to go up substantially. We need to do the full lung recruitment process that Anton described, and then come back down again to find optimal distending pressure. And with that, once you recruit the lung, it becomes more compliant. Your CO2 should come down if you're using fixed amplitude. If you're using VG, compliance changes won't affect the delivered tidal volume, but you might have less physiologic dead space, and that might improve. But CO2 is best addressed by adjustments to the tidal volume target. And there's nothing magical. Some babies need more than others.
So we are talking about high frequency ventilation. Okay, couple of comments on non-invasive high frequency ventilation.
The data are soft. Problem is, to me, the problem is in some circumstances it seems to work, but I don't know to what extent it really transmits the oscillatory amplitude through nasal prongs, through the turbinates of the nasal passages, and down into the airway. It's a bit of a leap of faith. I think a lot of the time there is some, because it's typically in that scenario used at high amplitude with 1-to-1 ratio, that there is probably some inadvertent PEEP that's being generated, and the babies are doing better because they needed more distending pressure. Regardless, in some babies it seems to work. I don't deny that it sometimes does, but I'm not convinced that it's really ventilating the babies as much as is optimizing lung inflation. We need better data. There are some small studies, but and it does seem to, as I said, work in some fashion. But just like nasal intermittent positive pressure ventilation at conventional rates, people think that it actually ventilates. It doesn't. It just increases the mean airway pressure.
I asked this question because the Professor Morarty, I think you were there in the SPIN meeting also, where they talk about the hierarchy of the non-invasive ventilation, and they compare the non-invasive positive pressure ventilation versus CPAP versus non-invasive high frequency ventilation, and they've showed a good result. So that's the only reason I asked this question.
No, the problem is comparing CPAP and NIPV is that the NIPPV was invariably used with significantly higher mean airway pressure. And we and others are showing that actually when you match the distending pressure, there is no difference, at least with non-synchronized. Now, Moretti, I think, has that Italian device that seems to be able to synchronize NIPV, and that probably does actually generate tidal volumes, and non-synchronized NIPV really doesn't. So, it's not that it doesn't work, but it probably works without synchronization. It probably works just by increasing the mean airway pressure. And there's a recent study came out that just published out of Australia that compared CPAP of I think it was 6 to 8 with 9 to 11, and showed much lower extubation failure rate with the higher CPAP of around 10 centimeters of water. Very few people outside of Australia use CPAP of 10 centimeters.
Yeah.
So NICV is a stealth way of getting to mean airway pressure of 10 without thinking that you're using CPAP of 10.
Yeah. Thank you, Dr. Kesler. Thank you very much.
So there are a few questions asking about what is the maximum MAP in a preterm baby or a term baby with high frequency. Do you have any specific numbers?
So I will tell you that what's important, more important than the absolute value of mean airway pressure is the mean airway pressure appropriate for the compliance of the baby's lungs. That said, very few babies, premature babies, need a really, really high distending pressure once you open up the lung. I don't know if everybody caught the nuance, but the lung recruitment process described by Anton is before surfactant. So these are surfactant deficient lungs, and they do lung volume recruitment with the oscillator prior to instilling surfactant, because they believe, and there's some evidence to support that surfactant distribution is more even when you administer it into a recruited lung. So the pressures that he was describing, well in the 20s, is not what you're going to see if you choose to give surfactant first, give surfactant in the delivery room, and then use distending pressure. That said, there are some babies, sick babies with other conditions that may require a fairly high distending pressure, but more than 20 would be unusual. But again, it's every baby is different, and I don't like to put absolute, limits. You can't go above X, because the available evidence tells us that it's not pressure but excessive volume, right, that causes problems and lung injury, and that pressure transmission to the mediastinum and impairment of venous return results from excessive distending pressure, excessive to the degree of lung compliance, rather than absolute level of pressure. So the important thing is, if you're having to use a higher pressure, is to make sure you try to reduce it, and not, once you achieve some recruitment, that you come down on the pressure, that you don't stay at the really high pressure. I certainly worry if I'm having to push the mean airway pressure to 25, but what else do you have? If the lung volume is still low and oxygenation, and the lung's still dense, and we might have to go higher. But as Anton pointed out also, if you repeatedly increase your distending pressure and see no improvement in oxygenation, you're probably not helping the baby by continuing to increase.
There is one question whether any role of graphics with high frequency.
Yeah, well, most of the modern high-frequency devices will give you graphics. You don't get pressure volume loops. You just get the basic flow, the three standard waveforms. No, you don't have the same kind of information that you get with conventional ventilation, and really the whole mechanics is so different that there is really no equivalent to those loops. But I think the most important graphic, if there is one, is monitoring the DCO2, because that very closely tracks with your transcutaneous CO2. It's less of a graphic. So it's a trend, though, right? So you can, if you're not using volume guarantee, it's really instructive to come in the morning and look at the trend overnight, what went on with your DCO2 and how it correlated with whatever was happening clinically.
Thank you. I mean, we'll wrap in 5 minutes if you're okay with that. I mean, one question is about use of SI breaths. I mean, I know some of the ventilators have the SI option with the SLA has, for example, mode, and would you suggest any changes? I'm not sure if Drager has as well, but
Draeger can produce psi breast, but it's not been well studied. It's controversial. The psi breast might be useful if you're like after suctioning or brief disconnection. If you in the lungs, there is some inhomogeneity of the lung, right? They're not all parts of the lungs have the same compliance. So theoretically, you might be able to use slightly lower distending pressure and periodically generate a psi. I don't know. We really can't say. We don't have good data to say that psis are or are not beneficial. I use psis for whatever it's worth with jet ventilation. So, but extrapolating from one device to another is probably fraught. If they are used, they should be used at a very low rate, like maybe 2 per minute, because psi is a psi. You don't psi 20 times a minute. But the good data are lacking.
Thank you. I mean, I think you have been very patient with answering all the questions despite having 2 lectures as well. I request the fellow panelists to comment or share their thoughts, and then we will close. I think Dr. Rajiv.
Yeah, because I still feel Martin has taught me again after 25 years with him. Every sentence he speaks, I registers in my computer and I use it appropriately sometime. So he is my Michael Shoemaker, who has given me the right strategy, the right lung, the right time. So all these 3 things he taught in 1997 still apply to me because I am able to effectively use it in the right situation, the right strategy. Thank you, Martin.